Hello friends, welcome to our biochemistry discussion for the elite test series that we have at the DocTutorials. So I'm Dr. Nilesh Chandra and you have already given the test series in three parts. We are going to be discussing each of the three parts today. So let's start with the part 1. Part 1, that is the carbohydrates and lipids. This was the test number 1 where we had a lot of questions coming in the last few years from the carbohydrates and the lipids. So we'll take them up one by one and I'll highlight all the important points that you need to know from these questions so that you're able to attempt all similar questions. These are the commonly asked topics coming in the exam and we'll make sure that you're able to crack them comfortably. So let's start. Starting with question number 1. Starting with question number 1. Just a second. Okay. Is the screen moving? Oh, there is some lag in the screen. Just a second. I'll open this again. I'm so sorry for this disturbance. Very sorry for the disturbance. Yeah, here we are. So question number 1. Question number 1. Which of the following pairs of sugars are both non-reducing? Now this is one of the very commonly asked question in your exam about reducing and the non-reducing sugar. Okay, so when we say reducing and non-reducing, first thing which you have to keep in mind is we are talking about the Benedict's test. So based on the result of the Benedict test, whether you get a positive result or you get a negative result. So the type of result that you are getting based on the Benedict test, we have the reducing and the non-reducing. If you have the positive result, we call it the reducing sugar, and you have the negative result, we call it the non-reducing sugar. We call it the non-reducing sugar. All right, so reducing and the non-reducing sugar. So as you can see, the question is asking here about the non-reducing sugar. So for that, the answer is going to be sucrose and trehalose. The answer is going to be sucrose and trehalose. This question is commonly asked to distinguish between the disaccharides. So let's take a quick look at which of the sugars will give the positive and the negative result. So all monosaccharides are reducing in nature. As you can see here, all monosaccharides, whether it is glucose, fructose or galactose, they are reducing in nature. Some of the disaccharides are reducing and some of the disaccharides are non-reducing. So you can see lactose, maltose, cellobiose, melibiose, even molecules like lactulose and isomaltose. These will also be the reducing disaccharides. On the other hand, the non-reducing disaccharides, the sucrose and the trehalose. So in this case, the trehalose is made up of glucose plus glucose, whereas the sucrose is made up of glucose plus fructose. Okay, so the common disaccharides reducing in nature are the lactose and the maltose. The common disaccharides which are non-reducing in nature are the sucrose and the trehalose. Okay, so that's about question number 1. Reducing, non-reducing, very common question. We should know the underlying test in this case is the Benedict test, and based on result we have either the reducing or the non-reducing sugars. All monosaccharides are reducing, some disaccharides are reducing, some disaccharides are non-reducing. Okay, let's go to question number 2. Following are the tests done for protein, sugars and ketones. So we have test 1 for protein, test 2 for sugars and test 3 for ketones. which will be positive in starvation state in the urine, and you have the various options of only one and two, only three, like that we have the various permutation and combination. So before we go there, you should be able to identify what tests are we dealing with. So number one I told you is for protein. This is the Biuret's test. This is for the protein. Number two is for sugar, and most of you know this is the Benedict's test. I'll show you the Benedict test again, don't worry. And number three, this is for the ketones. So this is the Rothera's test. This is the Rothera's test. So test for protein, Biuret, test for the sugars, carbohydrate, that is the Benedict test, and the Rothera's test, which is for ketones. Now the question says starvation state. In starvation state, what will happen? The sugar levels will be lower, and it doesn't mention whether the individual is having any other condition or not. So if the information is not given, we assume that kidney is normal. If kidney is normal, no protein. If there is no mention of diabetes, no sugar in the urine, so in that case only the ketone bodies will come out in the urine, and your answer should be only 3. Please keep in mind, the ketone bodies will come in urine in 3 conditions. First is the starvation as given in this question. In addition to that, they will also be positive in diabetic ketoacidosis, where obviously you will have the positive Benedict test because the sugar is coming out. And lastly, in the alcoholism, alright, in chronic alcoholism or in case of acute alcohol intoxication, these are the conditions where again you can get the increased amount of ketones. You can have the ketosis or the ketoacidosis. So there are 3 conditions where you find the ketone in the urine. Here it mentions starvation state, where you will only find the ketones. Okay, so let's quickly take a look at some of the tests which you can find in the urine, particularly for the carbohydrates and the other components. So we talk about abnormal constituents in urine. So abnormal constituents, reducing sugar. The test that we have here is commonly the Benedict's test. Then you have the protein. For protein, you can have the very common heat coagulation test. And then you have the ketone bodies, for which we already mentioned. You have the Rothera's test. These are some of the very common tests which can be done in a sample of the urine. Then we can have the bile salt and the bile pigment. For bile salt, you can have the Hayes sulfur powder test, and for bile pigments you can have the Fauchet's test. You can have the Fauchet's test for the bile pigment. In addition, you can have the blood, for which you can have the benzidine test. Okay, so these are some of the common abnormal constituent in urine. When we say abnormal constituent, what this means, in a normal individual, when you test for these components, they will not be present. There are a lot of components which are normally present in urine. For example, if you talk about electrolytes will be there, sodium, potassium, phosphate, etc. The urea will be there, the creatinine will be there. These are normal constituents. But when we say abnormal constituents, they are normally absent. They are totally absent normally, and in only certain cases they will appear in the urine. Okay, so these are some of the important abnormal constituents of urine. Nowadays we don't do the individual test. We have the kit like this, which we call the multi-stick. As you can see on this multi-stick, multiple slots are available. 1 2 3 4 5 6 7 8 9 10, like that. You can see multiple slots, even 11 slots are available, so you can test for 11 abnormal analytes. All right, and along with that we also have the control area. Control area is also there, which is used to validate the result, and based on that you are able to identify the blood, bilirubin, urobilinogen, ketone bodies, proteins, nitrites, the glucose, the pH, the specific gravity, and the presence of leukocytes, and this is the control or the compensation area. Okay, I can see in the chat whether this video will be available after the live end. Yes, it will be available for some time. It will be there on our feed for some time. Yes. Okay. So these are the newly available tests which we can quickly do on the multi-stick. We don't need to send the sample to the lab. However, if the compensation area is not correct, then we may need to send the sample to lab. Okay. On, like I showed you on the multi-stick, we have additional parameters: the specific gravity, urobilinogen, nitrites, pH, and leukocyte, which will tell us about the different conditions. Okay, so we mentioned some of the important abnormal constituents of urine and the corresponding test. I already told you, for reducing sugar we have the Benedict. For protein, the common test is the heat coagulation test. For the ketone bodies, common test is the Rothera's test, which is the modified nitroprusside test. For bile salt, we have the Hayes sulfur powder test, and for pigment we have the common Pochet's test. Now coming back to the Benedict test is for the reducing sugar. You can see the different colors can be there depending on the concentrations. Depending on the concentrations, we can have the different colors. So it gives us an idea of relative concentration, because of which the Benedict test is sometimes also known as the semi-quantitative test. It gives us the approximate range. It gives us the approximate range of the concentration, and therefore we call it the semi-quantitative test. Okay. Okay. Please keep in mind, Benedict test can also be positive for non-sugars. For example, ascorbic acid. For example, some even amino acids, the uric acid, all of these can give the positive Benedict test. So if someone has taken a vitamin C supplement the previous night, when he's giving the sample, the Benedict test might be positive. So you have to take a very good history before you are interpreting a positive result. An elderly patient where the hyperuricemia is there, uric acid is coming out in the urine, in those patients also you might sometimes find the positive Benedict test. Heat coagulation test, you can see how it appears. The upper part is heated. If the protein is present, it will give the cloudy appearance. With the help of the glacial acetic acid, you confirm whether it is due to the protein or the phosphate. This is another very common bedside test that we can do, commonly done in patients of the nephrotic syndrome, to assess the response to treatment. In the hospital setup, we can commonly do this test. And then here you can see the Rothera's test for ketone body. This is the positive result, and here you have the negative result. Negative result when the ketone bodies are not present. Okay. To distinguish between the different reducing disaccharides, we can do the Osazone crystal test. We can do the Osazone crystal test to distinguish between the lactose and the maltose. What happened? To distinguish between the lactose oh, I'm sorry for this ongoing disturbance. Okay, to distinguish between the lactose and the maltose, we can do the Osazone crystal test. So I'll show you the different tests for the carbohydrates, how they look like, and the appearance. Okay, so for all carbohydrates, we have the common test, which is the Molish test. For polysaccharides, we have the iodine test. For monosaccharides, we have the Barford test. And for the ketones, we have the Selivanov test. All reducing sugars, as you already mentioned, will have the positive Benedict test. Let's see. Molish test, you can see something similar to the Rothera's test. That is why I'm showing you, so that you are able to distinguish between the Rothera's test and the Molish test. It appears, the ring appears like the Rothera's. We'll put both the slides together at the end and we'll see, we'll do the comparison so that this confusion is not there. Okay, so the ring structure similar to the Rothera's. This will be given for all the carbohydrates. All carbohydrates will give the positive Molish test. Then iodine test, commonly for starch, you can see the blue-black color. The blue-black color, which is for starch. In case you have the glycogen in the sample, in that case you can get the wine red color, commonly done for the tissue staining where we are looking for the glycogen stores. So there you can do the staining with iodine and you're going to get the wine red color for the iodine. Okay, then we have the Barford test. Barford test will help to distinguish between the reducing monosaccharide and the reducing disaccharide. Remember, we had done the Benedict test, which is positive for both the monosaccharides and the disaccharides. To distinguish, we do the Barford test, which is positive only for the monosaccharides. And then we have the Selivanov test, which will distinguish between the keto group and the aldehyde group. So ketose sugar and the aldose sugar, they can be distinguished using the Selivanov test, which is positive for the keto group. For example, if you want to distinguish between fructose and glucose, fructose will give the positive result. This is the cherry red color. Cherry red color will be seen with the Selivanov test. Okay, and then we have the Osazone crystal test. Osazone crystal test used to distinguish between the different reducing disaccharide. Okay, so we have the lactose and the maltose. How to distinguish between them using the Osazone crystal test? Maltose will give you the sunflower shaped crystals. You can see here the sunflower shaped crystals are there, which can be seen with maltose. Whereas in case of lactose, we have a distinctly different shape of the crystals. In case of lactose, we have the pin cushion shaped crystal. So here you can see a central dark portion and the lighter portion is there. Sometimes this is also known as the hedgehog shaped, or it is also known as the cotton ball shaped. They are the different terms which are used to describe the crystal that you get in case of the lactose. In case of lactose, we get the hedgehog shaped or the pincushion shaped or the cotton ball shaped crystals or the cotton ball shaped crystals. This is creating a lot of problem. So sorry, this mirroring is getting stuck again and again. Network issues. Very sorry for this network issue. Okay, it keeps skipping my connection with the iPad. I'm so sorry. Okay, so the pincushion shaped or the hedgehog shaped, also sometimes described as the cotton ball shaped crystal for the lactose. Okay, when you do it for the common monosaccharides, whether it is the glucose or maybe it is fructose or maybe it is mannose, for all of these you will get the needle shaped crystals. Needle shaped crystals for glucose, fructose or the mannose. Okay, take a quick look. Molish versus Rothras. Molish versus Rothras. In Molish, you can see both the layers are clear. In Rothras, you can see the lower layer is still brown in the positive test. So this is how you can quickly distinguish between Molish and Rothras. Molish is for all carbohydrates, whereas the Rothras is for the ketone bodies. So please make sure you identify these colored images that I have shown you based on the tests. Very commonly we are getting the colored images in the exam. You just saw the question number 2 where we had different images for the different tests. So you should be able to identify the test. Based on that, you should be able to extrapolate what analyte we are testing for, which analyte is coming out to be positive. Very, very important information. Okay, let's move on to next question. Question number 3. Most important rate limiting enzyme of glycolysis is PFK1, pyruvate kinase, glucose 1,6 bisphosphatase, hexokinase. So here First of all, I would like to say that rate limiting enzyme. This is the most important question. So whenever you're doing the revision for the pathways, make sure you know the rate limiting enzyme for the different pathways. Almost always asked in your exam at least one question on rate limiting enzyme. In this question, it is written the most important rate limiting enzyme, but most of the time the most important term is not written, it is implied that you have to mark the most important rate limiting enzyme. For glycolysis, the most important rate limiting enzyme is the PFK1. PFK1, that is the phosphofructokinase 1. Okay, so this is the most important rate limiting enzyme, and it is under various types of regulation. So here what I'll do, I'll quickly tell you the important regulation which occurs in the glycolysis, which all enzymes are getting affected, what are the molecules which affect the enzymes in regulation of glycolysis. Very important question, very frequently asked in your exam. So first in this series is the PFK2, which is targeted by the hormones, and please note it is active in the dephosphorylated state. It is active in the dephosphorylated state. Then we have the PFK1. PFK1 is under allosteric regulation. The activators include the AMP, fructose 6-phosphate, and the fructose 2,6-bisphosphate. Inhibitors include the ATP and the citrate, right? And then we have the hexokinase. Hexokinase will show the feedback inhibition by glucose 6-phosphate. It will show the feedback inhibition by glucose 6-phosphate. Please note, hexokinase is not affected by hormones. This is another commonly asked question, which of the following enzymes of glycolysis is not affected by hormones. So there you are going to mark hexokinase. Hexokinase is not affected by hormones, rather it only shows the feedback inhibition by the glucose 6-phosphate. Okay, please note here that PFK2 gives rise to the fructose 2,6-bisphosphate, which in turn activates the PFK1. So the hormones indirectly are regulating the PFK1. So PFK1 still shows some amount of hormonal regulation, whereas hexokinase does not show any effect of the change in hormone concentration. In addition to that, what you have to remember, glycerolide 3-phosphate dehydrogenase is inhibited by iodoacetate. It is inhibited by iodoacetate. The enolase is inhibited by sodium fluoride and the 3-phosphoglycerate kinase. This is bypassed. This is bypassed by arsenite. It doesn't inhibit the enzyme, it bypasses the reaction which is normally catalyzed by the 3-phosphoglycerate kinase. But in this process, normally ATP is formed. When arsenite is present, ATP is not formed. That is why we have this term uncoupler of glycolysis. Arsenite will act as the uncoupler of the glycolysis. Okay, so these are the three important non-physiological regulators of the glycolysis. Okay, moving on to question number 4, identify the correct regulatory molecule. As you can see, this is the pathway of glycogen metabolism, glycogen synthesis, and the glycogen breakdown. Cyclic AMP is the main regulator which affects both glycogen synthase and the glycogen phosphorylase. So you can see here A is activating glycogen synthase and B is activating the glycogen phosphorylase. So you know that increase in glycogen synthesis is done by insulin. So A must be insulin, and increase in glycogen breakdown is done by glucagon. So B must be glucagon. So in this case, the answer is insulin is A and glucagon is B. In place of glucagon, we can even have epinephrine. We can even have epinephrine. Epinephrine, glucagon, both of them are going to induce the glycogen breakdown, whereas the insulin is going to promote the glycogen synthesis. Okay, moving on to question number 5, clinical case. A child was brought to hospital, was found to have hypoglycemia. hepatomegaly, an accumulation of highly branched glycogen called limited extent. So as you can see, this is a case of the glycogen storage disorder. He is likely to be suffering from which of the following conditions: McArdle, Anderson, von Gerke, and the Cory's disease. So what you can see here, there is accumulation of highly branched glycogen. The highly branched glycogen will accumulate when the debranching enzyme is not there. Again, the mirroring is lost. I'm very sorry, the connection is fluctuating today, because of which we are losing the screen again and again. Okay, I think it's back. Is it? Yeah. So you can see here, highly branched glycogen. Highly branched glycogen will be formed when the debranching enzyme, is absent, and the debranching enzyme is absent in the Cory's disease. See, very simple way to remember: in Cory's, the debranching enzyme is absent. In Anderson's, the branching enzyme is absent. In McArdle's, the myophosphorylase is absent. In hers, the hepatic phosphorylase is absent. This is how you can remember the enzymes: type 3 which is Cory's, type 4 which is Anderson's, type 5 which is McArdle, and type 6 which is hers, in which the corresponding enzymes are absent. D is for debranching enzyme and B is for the branching enzyme. Okay, so this is how we can remember the debranching enzyme: C followed by D, A followed by B, M with M, and H with H. This is how you can quickly remember the important enzymes and in which condition of the glycogen storage disorder they are deficient. Okay, so in this case you can see the debranching enzyme is deficient, which is commonly absent in the Cory's disease. We get a lot of questions from clinical cases from glycogen storage disorder. I think we have one more question here from the glycogen storage disorder. Take a look here. Female infant appeared normal at birth but developed signs of liver disease 1 month of age and muscle weakness at 3 months. Severe hypoglycemia on early morning awakening. This is an important indication which is given in the question. Then what we find: examination reveals hepatomegaly, laboratory analysis shows ketoacidosis, pH 7.2, increased AST and ALT. Intravenous administration of glucagon followed by glucose normalized the blood levels, but glucose level did not rise when glucagon was administered after overnight fasting. This is another important clue. Glucose level did not rise when glucagon was administered after overnight fasting. When you see these two statements in the question, hypoglycemia after overnight fasting, which does not respond to administration of glucagon, again you have to think about type 3, that is the Cory's. And like we said, in Cory's the deficient enzyme is the branching enzyme. So you can see similar question, but the clinical presentation is described differently and the options are also differently. Previously we had to make the diagnosis. Here you don't have to only make the diagnosis. After making the diagnosis, you have to tell the enzyme which is deficient. In this case it will be the, again, debranching enzyme. The debranching enzyme will be deficient. Moving to question number 7, you can see again a 10-year-old boy present emergency with fainting episode during playing football. Blood examination reveals hypoglycemia, raised levels of ketone bodies, lactic acid, triglyceride. On examination, liver and kidney are enlarged. This is a key information. When liver and kidney are enlarged together and you are thinking of glycogen storage disorder, then you have to think about type 1, which is the von Gerke's disease. So in this case, the answer should be von Gerke's disease. Important thing to remember here is the glycogen will be normal. Normally formed glycogen will be there. The normal glycogen will be there in this case. Okay, so some of the very important and the common, glycogen storage disorders and the clinical case, particularly for type 1 and type 3. These are very commonly asked in exams. Sometimes you also might get the question on type 5. So these are some of the important cases which you must keep in mind. Glycogen storage disorder is very important. Very frequently, almost every exam we get a clinical case from that question. Very good. Okay, question number 8. Pyruvate can be converted directly to all of the following except, and you can see the options here: phosphoryl pyruvate, alanine, acetyl coenzyme A, and lactate. Anyone would like to hazard a guess? What do you think is the answer in this case? Anyone? Okay, no problem. So please take a look. Pyruvate can get converted into various substances in the cytoplasm or inside the mitochondria. In the cytoplasm, it can get converted either to lactate or it can get converted into alanine by transamination. On the other hand, inside the mitochondria, it can be converted into oxaloacetate or it can be broken down into the acetyl coenzyme. These are the fates of the pyruvate. In the cytoplasm, we have the different fate. In the mitochondria, we have different fate. Please note the reactions in cytoplasm are reversible, whereas the reactions inside the mitochondria are irreversible. So that oxaloacetate will commonly go for the gluconeogenesis, and this acetyl coenzyme will commonly go for the Krebs cycle. Okay, so these are the products which we get. As you can see, the phosphoenol pyruvate cannot be generated directly from pyruvate by the reversal of the reaction. We are looking at the irreversible reaction, so the backward reaction will not happen. Okay. Question number 9, you can see again a clinical case is there. Exclusively breastfed neonate presents to emergency in the 7th month. This is the key information. 7th month of life with complaints of vomiting, lethargy, and poor feeding. These are neurological in nature. So neurological signs and symptoms at the age of 7 months. The respiratory duty obviously will suspect the inborn error of metabolism. Urine examination was negative for glucose oxidase test. Glucose oxidase test is very specific for glucose, but it is positive for Bandic test for reducing substance. Most likely inborn error of metabolism is. So here what you have to keep in mind, the age of presentation. Whenever you see any specific age which is just greater than 6 months where you have the neurological signs and symptoms, so immediately you have to think about the hereditary fructose intolerance. What is the importance of the age 6 months? This is when we start doing the weaning. When you start doing the weaning, then you'll add the fruits, fruit juice, fruit pulp, solid fruit, which will contain the fructose. So fructose related disorder will become apparent at the age greater than 6 months when the weaning has been started. Okay, you start the weaning and then the presentation will come. If you start the weaning late, the presentation will come late. If you start the weaning early, the presentation will be earlier. Okay, please note, in case of galactosemia, the age of presentation will be 3 to 6 days. So within the first week of life, the child will be brought to the hospital, and presentation is similar. Neurological signs symptoms will be there, but it will come within 3 to 6 days. The neonatal diabetes mellitus will also present in less than 6 months. In case of essential fructosuria, you don't have any signs and symptoms. It will be an incidental finding. You are investigating for some particular specific disease, and along with that, incidentally you find out, okay, this person is also having the essential fructosuria. Okay, please note, very important question, very commonly asked in the form of clinical case. What you have to keep in mind, that presentation will occur after the weaning has been started. Okay, so if the weaning has been started after 6 months, presentation will be after 6 months. Okay. Question number 10. In the given glucose tolerance test graph, you can see A and B. What does graph B denote? Alright, so you can have the option of uncontrolled diabetes mellitus, impaired glucose tolerance, renal glycosuria, and normal individual. So for normal individual, you should know the values, that the fasting value is less than 100 milligram percent. Okay, and the 2-hour value should be less than 140 milligram percent. So you can look at these two values and quickly you can find out whether the individual is normal or not. This is obviously as per the ADA. This is as per the ADA. Based on that, you can quickly identify whether it is normal or not. So let's see. Graph A, up point at fasting, it is less than 100. So okay. And at 2 hour, again, it is in the range of 100. So A is normal. A is normal individual. It satisfies both the condition 1 and condition 2. In addition, what you have to keep in mind, in a normal individual, the value will never be greater than 180 milligram percent. Why 180 milligram percent? 180 milligram percent is the concentration which we call as the renal threshold. If the concentration is below this, then the kidney is able to absorb all the glucose from the ultrafiltrate. Okay, so never it will go above 180. Okay, so look at graph B. I'll show you the complete GTT graph where it will be easier to understand. Okay, so normal, we said the value will be less than renal threshold. You can see here that peak value is less than renal threshold and it comes back to baseline by 2 hours. In case of renal glycosuria, what do you find? That the values are less than renal threshold, and still in this case what will happen in renal glycosuria? There will be glucose in urine. Glucose in urine can be there when the blood glucose levels are more than 180. But if the glucose in urine is there, if the values are less than 180, in that case we call it the renal glucosuria. Otherwise, we don't call it renal glucosuria. In some cases, what you find that the 0-hour value and the 2-hour value are normal, but the peak value is greater than renal threshold. In these cases, what will happen? You will find the glucose in urine. This is not renal glucosuria. Why? Because the renal threshold has been crossed. On the other hand, there are individuals where you have the fasting value more than 100 and the uh, peak value is definitely greater than renal threshold, and 2-hour value is greater than 140. 2-hour value when it is greater than 140. So these are the cases where the normal control is disrupted. But to call the patient as diabetic, we have the different parameter. Greater than 126 for fasting, greater than 200 at 2 hours. Based on that, we'll call the patient as diabetic. So you can see here, diabetes 2-hour value greater than 200, and in severe cases, obviously much higher value will be there. Let's go back to the question. You can see here B 0-hour value is greater than 100 and the 2-hour value is greater than 140, but it is less than 200. So this is not a diabetic patient. Okay, you can see this is not a diabetic patient. Peak value is greater than 180, so you cannot comment on the renal glycosuria. So you cannot call it renal glycosuria. This is not uncontrolled diabetes mellitus. This is not an normal individual. So this is a case of impaired glucose tolerance. We call it the impaired glucose tolerance when the values are between 100 to 125 in fasting and between 140 to 199 in the 2-hour. This is called the impaired glucose tolerance. Alright. So diagnosed as the pre-diabetic individual where the values are like that. So you might find the glucose in urine in these patients, but when you do the 0-hour and 2-hour measurement, you find that that is normal. Okay, so in that case you have to do the extended GTT where you take the values after every half an hour, or nowadays we have available what is known as the continuous glucose monitoring system. Please note, this is a new facility which is available. The continuous glucose monitoring system is a very simple small patch like thing. A patch like this is there, and this patch can be stuck on the arm. Okay, you stick it on the arm and it will continuously measure the blood glucose maybe after every 15 minutes, or the higher versions can take the reading whenever you want in addition to that 15 minutes. And With the help of a sensor, you can read out the readings using the Bluetooth or the Wi-Fi. It will take the readings which have been measured, and then you get the continuous value for about 14 days from these patients. The continuous sampling is there, so you get a continuous graph. So it will give you a very clear cut picture what is the fluctuation in the blood glucose over 24 hours for 7 days, for 14 days. Okay, so it measures the values every 15 minutes for 14 days. Okay. In India, the available version is from one of the multinational companies, Abbott. It is having the readily available commercial sample, which is being used by diabeticians to find out the fluctuation in the blood glucose in the diabetic patients. So diabetologists will make use of this continuous glucose monitoring system, which is pretty non-invasive. It can just be given as a patch. Okay. Moving on to question number 11, very common question based on classification. Which of the following is a homopolysaccharide? Here you have to remember chitin is a homopolysaccharide made up of N-acetyl glucosamine. The others are heteropolysaccharide. The others are heteropolysaccharide. In fact, most of them are the glycosaminoglycans. So take a quick look. Classification. The polysaccharides can be homopolysaccharides, they can be heteropolysaccharides. Homopolysaccharides, same repeating unit. So if you have the glucose, you can have starch, glycogen, cellulose, dextrin, dextran. For fructose, you can have inulin, and for N-acetyl glucosamine, we have the chitin. Okay, so you can see that we have the homopolysaccharide where the same repeating unit is there, and you have to specifically remember chitin is also a homopolysaccharide. This is where we tend to get confused that chitin, oh no, this doesn't look like homopolysaccharide. Please remember this is also a homopolysaccharide. Then we have very commonly the question is available on isomerism. So here you have the question, galactose and mannose are what type of isomers of each other? Your options are epimer, diastereomer, enantiomer, and anomer. So very quickly I'll show you which are the different types of isomerism, and then we come back to this question. So you can see isomerism in carbohydrate based on chiral carbon. Based on chiral carbon, we have two types of isomerism. We have the enantiomerism, and we also get what is known as optical activity. In enantiomerism, we have the D and the L forms. D and the L forms. So what is happening here? They are mirror images. All the functional groups will be arranged in the opposite direction. Okay. Now we have the less important form, which is the diastereomerism, where some similarity is there in the orientation around chiral carbon. And here we have the epimerism. This is a very commonly asked question. Glucose and mannose are epimers at carbon 2, GM2. Glucose and galactose are epimers at carbon 4, GG4. Okay, so GM2, glucose and mannose epimer at carbon 2, glucose and galactose epimer at carbon 4. Please note, if you compare the mannose and galactose, in that case what you get is a diastereomer. They have some similarities, but they are also different at two different carbons. They are different at carbon 2 and carbon 4. In epimers, what is happening? Difference at only one chiral carbon. When the difference is there at only one chiral carbon, in that case we get the epimerism. Examples are glucose and mannose, glucose and galactose. Glucose mannose at carbon 2, glucose and galactose at carbon 4. Okay, then we have the ring structures based on the differences. We have the pyranose and the furanose form. The furanose will have 5 members in the ring. Pyranose will have 6 members in the ring. How do you remember this? F for 5, F for furanose. F for 5, F for furanose. So furanose will be the 5-membered ring. The pyranose will be the 6-membered ring. And then the ring structure, we have another isomerism called the anomerism. So anomerism is seen only in the ring structure. In the linear form, the aneurysm is not seen. So here we get the alpha and the beta forms. Lastly, based on functional groups, we have the aldose and the ketose. In aldose, the functional group is obviously the aldehyde, and in ketose, the functional group is the keto group. Okay, so based on that, you have the different types of isomerism as seen in the carbohydrates, the enantiomerism, diastereomerism, subtype epimerism, the ring structures, the anomerism, and the functional type of isomerism, which is the aldose ketose forms. Okay, so now we go back to our question. So galactose and mannose we just mentioned are diastereomers of each other. They show differences at both carbon 2 and carbon 4. Alright, they are not epimers. Very common mistake we make when galactose and mannose, both of them are epimer of glucose, so they are epimer of each other. No, it doesn't work like that. Okay. Moving on to question number 13, method of transport of glucose in the intestines. Now you can see various options: primary active transport, secondary active transport, simple diffusion, counter transport. Now, what you have to note, primary active transport is present in the intestine, but it is not working for glucose. The simple diffusion is available, but very little amount of glucose getting entry through this. The counter transport, again, it is active in the form of primary active transport, but it is not for the glucose. So among the available option, the best answer is secondary active transport. In addition to this, the option could have been the facilitative transport. Both of these are working for the transport of glucose in the intestine. The secondary active transport and the facilitative transport. Secondary active transport is a symporter. It also brings in sodium, and the facilitative transport is there. So facilitative transporters are the GLUT. The secondary active transporter are the SGLT. Okay, GLUT5 on the luminal surface, whereas GLUT2 on the basolateral surface. So these are the different types. These are the different types of the transporters which are present on the intestinal cells. Okay, the SGLT1 and GLUT5, they are present on the luminal surface, whereas the GLT2 is present on the basolateral surface. Okay, please note, nowadays we also have the SGLT2 inhibitors. The SGLT2 is commonly present in the renal cells. The SGLT2 inhibitors are commonly used for control of sugar, particularly in the type 2 diabetes mellitus. In type 2 diabetes mellitus, nowadays we have the SGLT2 inhibitors which are commonly being used. Some examples, if you want, I can mention dapagliflozin. Yes, gliflozins. Very good. Saurav Pradhan has given the name. Canagliflozin, dapagliflozin, canagliflozin, and epagliflozin. So these are some of the three available compounds which are there for the inhibition of SGLT2. It prevents the reabsorption of the glucose which has been filtered at the level of kidney, so that large amount of glucose getting lost in the urine and blood glucose level will come down. Please keep in mind, this is a very likely question, and the dapagliflozin or canagliflozin or the epagliflozin, which transporter, which molecule they are targeting, your answer should be SGLT2 in the renal cells. In the renal cells, they are targeting the SGLT2. Very recently available drugs, you will talk about them in your pharma also, but I'm associating with the transporters. You have to keep in mind about the glucose. Okay. Tricky question. Only anaerobic glycolysis occurs in all except. Please note, lens, RBC, cornea, they have purely anaerobic glycolysis. Why? In RBC there is no mitochondria. In lens there is no oxygen. In cornea there is no oxygen. Why? They are avascular structures. The lens and cornea are avascular structures, so they do not get the oxygen. But CNS gets large amount of oxygen, right? However, it has both, because the available oxygen is not enough. So both anaerobic plus aerobic glycolysis, both of them are required. Okay, so CNS will show both aerobic and anaerobic, whereas lens, RBC, cornea and subepithelial layer of skin and GIT, also avascular, they will also show only anaerobic glycolysis. Okay, question number 15, you can see it is based on the metabolic pathway and the absence of the various enzymes which gives rise to the inherited disorder. We have mentioned this in the form of clinical case previously also. So fructokinase, if it is not there, fructose level will rise. Only fructose rising in the blood is not going to cause any problem. So it is asymptomatic. We had mentioned asymptomatic means essential fructosuria. B, aldolase B is not there, fructose and phosphate will start accumulating, cause all the signs and symptoms. So this is the hereditary fructose intolerance. Option A is the correct answer. Please note, if fructokinase is not there, we get the essential fructosuria. If the aldolase B is not there, in that case we get the hereditary fructose intolerance. Very, very important. We have already discussed the clinical case for the hereditary fructose intolerance. Age of presentation will be 7 months. Okay, question number 16, another important question, glucogenic versus ketogenic molecules. What you have to remember, all amino acids. We'll quickly talk about the glucogenic substrates, all amino acids except lysine and leucine, right? In addition to that, we have the lactate, we have pyruvate, we have glycerol, and lastly we have odd chain fatty acid, right? So now there is a problem. There are two options which do not come in this list, and that creates a confusion. So what you have to remember, that oxaloacetate is a common and important intermediate. Alright, it is a common and important intermediate. So if you have to choose the best possible answer, the answer would be acetyl coenzyme A. It is never glucogenic, because once it enters the Krebs cycle, by the time the molecule can go for gluconeogenesis, 2 carbon have already been lost by decarboxylation. So acetyl coenzyme A can never be glucogenic. Please keep this in mind. Acetyl coenzyme A can never be glucogenic. Okay, so this is very important. Question number 17, again important question, which of the following enzyme is common between glycogenesis and glycogenolysis? So these are two separate pathways, one pathway giving rise to glycogen synthesis, another one causing the breakdown of the glycogen. Only one common enzyme is there, and that common enzyme is the phosphoglucomutase. What it does? Glucose 1 phosphate and the glucose 6 phosphate, the interconversion is done by the phosphoglucomutase. The interconversion between glucose 1 phosphate and glucose 6 phosphate is done by phosphoglucomutase. This is the only common enzyme in the two pathways. 3 ATP in anaerobic glycolysis occurs with which fuel? Very important question again. How many ATP are you getting from the different types of glycolysis? So very quickly I'll show you something here. Glycolysis, if you have anaerobic or you have aerobic, you can have different values. You can have 0 or 1 ATP, you can have 2 ATP, or you can have 3 ATP. In case of aerobic, you can have 5 ATP or you can have 7 ATP. Very important to know that different values based on different conditions. This one is for RBC. This is the common one. This will occur in skeletal muscle. This will occur in the CNS. This will occur in the liver, in the kidney. Okay, so you have to remember these values. For liver or kidney we have 7 ATP. Here we have the malate aspartate shuttle. Here in the CNS we have the glycerol 3 phosphate shuttle. Glycerol 3 phosphate shuttle is there in CNS, so we have 5 ATP. In skeletal muscle, glycogen is providing the fuel, so less ATP required. And in RBC you have what is known as the Rappaport Lou-Behring shunt, which makes up which uses some of the available triuses. ATP form is less. Okay, so 3 ATP in anaerobic glycolysis is coming from the glycogen. It is coming from the glycogen. Okay, moving on to question number 19. Insulin glucagon ratio decreases in all except options are gluconeogenesis, glycogenolysis, ketogenesis, and glycogenesis. So see, I tell the students all the time that this question appears to be very complicated, but if you are very careful, it is a simple question. First thing to understand is whenever you get the insulin glucagon ratio, please cut out the term glucagon ratio. Now we are only talking about insulin. Okay, so the insulin decreases in all except. Okay, so this becomes a bit confusing. First we are talking about decreasing and then we say all except. Okay, so what do you do? You remove the decrease and except. So what we want to know, insulin increases in which one? Increased insulin will be available for which of the pathways? Now when the insulin is available, what it will do? It will try to use up all the glucose. Okay, so you have to look at pathway which is making use of glucose. Gluconeogenesis, no, it is making glucose. Glycogenolysis, it is again making glucose. Ketogenesis, it is making the fuel. Glycogen synthesis, this is using up the glucose. So when insulin is there, the glycogen synthesis will take place. So what you have to keep in mind, first, when you get the insulin glucagon ratio, okay, in that case you remove the glucagon ratio, you just read it as insulin. And whenever you have decrease all except two negatives are there, you remove the negatives so that the question becomes more simple. In this case the answer is glycogenesis. Here you should know which are the pathways which are upregulated by insulin, which are the pathways which are downregulated by insulin, so that commonly we get this question and you are able to solve it. So like I said, the insulin will activate all those pathways where the glucose is getting consumed. So here you have the glycolysis, glycogen synthesis, lipid synthesis, HMP shunt, amino acid synthesis. You can also add the cholesterol synthesis. All these pathways will be activated when insulin is there. Any pathway which generates a fuel, whether it is glucose or the ketone bodies, they will be down regulated by insulin. Means glycogenolysis, the lipolysis, gluconeogenesis, and even the ketogenesis, all of them are negatively affected by insulin. And please note, the primary action of insulin on the enzymes is dephosphorylation. So if you remember this, then a lot of questions become simpler. Which enzyme is active in the dephosphorylated form, which enzyme is active in the phosphorylated form? So answer will come from there. See, all the enzymes of this pathway, they will be active in the dephosphorylated form, but these enzymes will be inactive in the dephosphorylated form. They will be active in the phosphorylated form. So from here itself we are also getting the answer which enzymes are active in the phosphorylated form and which enzymes are active in the dephosphorylated form. This is another very important question for us which you have to keep in mind. Last thing, remember, insulin is increased in fed state. So when the fed state is there, insulin will be increased. So these pathways will be upregulated, these pathways will be downregulated. So again, you get the answer for the another question. What happens in fed state? What happens in the fasting? Okay, so from one slide we have answered 4 questions. Insulin glucagon ratio, actions of insulin, what happens in phosphorylated state, which enzymes are active in dephosphorylated state, and what happens in the fed state or the fasting state. So just by one slide we are able to answer multiple questions. Okay. Question number 20, which of the following enzymes is not elevated in fasting? Okay, so again, it says not elevated and it says fasting. So remove both. Which enzymes is activated in the fed state? Again, in the fed state, the fatty acid synthesis, lipogenesis is activated. So only enzyme among the first 6 pathways is acetyl coenzymic carboxylase, which is part of the lipogenesis. Okay, so in fed state, lipogenesis will be upregulated. Enzyme is acetyl coenzymic carboxylase. Hormone sensitive lipase is lipolysis occurs in the fasting state. Lipolysis occurs in the fasting state. Glycogen phosphorylase is glycogenolysis, and CPS1 is part of urea cycle. Urea cycle is also upregulated in the fasting state. Okay. Okay. Uh, don't be worried if you give wrong answers here. This is for your practice and revision. So a wrong answer here is actually useful for you. You'll not make the same mistake in the exam. So don't worry about giving the wrong answer. It would be a good idea for you to write answers. Whether it is right or wrong is secondary. We are all here to learn and revise our syllabus. All right. Lactose intolerance will be least for. Here you have to understand lactose intolerance is due to lactose. So some of these food stuff may not have lactose, and the answer is yogurt. Due to the presence of lactobacillus, all the yogurt has been used up. So lactose intolerance will not be there. Lactose intolerance is due to the inherited deficiency of the enzyme lactase, which is responsible for metabolism of lactose. So if inherited deficiency is there, then you will have the GI signs and symptoms: bloating, flatulence, abdominal cramp, diarrhea. All these things will be there in case of lactose intolerance when the lactose is consumed. In other words, when the milk is consumed. Exception being substances where lactose is less in amount, particularly yogurt, you can even have curd. These substances will not have lactose. Question number 22. In electron transport chain, protons are pumped across inner mitochondrial membrane by all except. Okay, so here we have options complex 1, 2, 3, 4. What you have to remember, complex 2 does not pump protons. Complex 1 will pump 4 protons. Complex 3 will pump 4 protons. Complex 4 will pump only 2 protons. Okay, so the complex 1, 3 and 4 will pump protons. Complex 2 does not pump protons. Okay. Question number 3. Now we come to inhibitors of the complexes, and here you can see you can get the names of the complexes instead of only the number. You can also get the name of the complexes. Okay, so you have to know which complex has what name. In the past we have only talked about complex number 1, complex number 2, 3 and 4, but here I'm telling you that you should also know the names. Okay, so Q cytochrome C oxidase is actually complex number 3, and now the question becomes simple. Complex 3 is inhibited by, the answer is fenformin. Complex 3 is inhibited by fenformin. You know, cyanide is inhibiting the complex 4, demerol is inhibiting complex 1, malonate is inhibiting the complex 2, fenformin is inhibiting the complex 3. Okay, fenformin is inhibiting the complex 3. Okay, so you can see here the composition, the components. Complex 1 known as NADHQ oxidoreductase. Okay, the complex 3 known as Q cytochrome C oxidoreductase. Complex 2 known as succinate Q reductase, and complex 4 known as the cytochrome C oxidase. Okay, so 3 is Q cytochrome C oxidase, which is asked in the exam, and 4 would be cytochrome C oxidase. 4 would be cytochrome C oxidase. So if you go back to the question, so they've asked Q cytochrome C oxidase, complex 3, which is inhibited by fenformin. 4 would be the cytochrome C oxidase. Okay, very quickly we'll go through the list of inhibitors of electron transport chain. You can see important molecule here. The demerol is there, the amobarbitol is there, rotenone is there. These are inhibitors of complex 1. In complex 2, the important molecule is the malonate. Malonate is the important molecule which is inhibiting the complex 2. In complex 3, the important molecule is the fenformin. Fenformin, you can also write here the metformin, but they will be able to inhibit the complexes only when they are in significant concentration. Okay. So if metformin will be accumulating inside the body, if it inhibits the complex 3, it causes a condition known as MALA. Metformin associated lactic acidosis. Metformin associated lactic acidosis can be there when there is accumulation of metformin. If patient has CKD, still taking the metformin, in that case you will have the metformin associated lactic acidosis. And complex 4, hydrogen sulfide, carbon monoxide, cyanide, azide. This is one of the commonly asked questions. Okay. Moving on to question 24, inhibitor of ATP-ADP translocase. Okay, ATP-ADP translocase, it will bring out the ATP which has been synthesized in the matrix and exchange for another ADP. So answer here is atractyloside. This question has been asked quite a few times. You should know ATP-ADP translocase is inhibited by atractyloside. Oligomycin is the inhibitor of the F0 of the ATP synthase, sometimes also known as the complex 5, sometimes also known as complex 5. Oligomycin and even venturecidin. Venturecidin will inhibit the F0 of ATP synthase. Tentoxin will inhibit the F1 and even efrapeptin. These will inhibit the F1. Very good. Okay. So here the answer is atractyloside. You should know the other molecules, how and where they are acting. Oligomycin and venturecidin will act on F0, whereas tentoxin and efrapeptin will act on F1. So this is listed here. Oligomycin and venturecidin acting on F0, tentoxin, efrapeptin acting on F1. Atractyloside is inhibitor of the ATP-ADP translocase. Please make note of this name, abomycin. The other name for venturecidin. The other name for venturecidin is abomycin. Okay. Then we go to question 25. Question 25 is about a very important topic, respiratory quotient. Respiratory quotient is very frequently asked question in the exam. It has come multiple times in the last few years. After heavy carbohydrate meal, so what should be the value? You have the different options, 0.8, 1.2, 1, 0.7. For this, you should know the respiratory quotient value of the different macromolecules. Let's take a look. First, for carbohydrates, the value is 1. For proteins, the value is 0.8, and for fat, the value is 0.7. So if you have a balanced diet, or you can say you have a mixed meal, here the RQ should be roughly 0.85. On an average, the value should be 0.85. But if you have more of carbohydrate, we had the question carbohydrate heavy meal, then it will be closer to 1, and that is why here the answer would be 1. Okay, respiratory question after a heavy carbohydrate meal will be 1. Very good. Saurav has given the correct answer. Okay, question number 26. Glycerol is not present in. Now here you have to remember, when we talk about lipids, we have the two important alcohols. One is glycerol, The second is sphingosine. These are the two important alcohols which are present in the important and the common complex lipids. Glycerol is very widely distributed. Most of the lipids are going to have the glycerol except for one group of molecules which are having the sphingosine. So sphingosine will be present very good in the ganglioside, which is a glycolipid, glycolipids, and the sphingomyelin. These are two group of molecules where sphingosine is present. Okay, glycolipids and sphingomyelin contain sphingosine. All other lipids are going to have glycerol, whether it is the fats or the oils or the waxes, the glycerophospholipids, all of them will have the glycerol as the alcohol. Okay, these are commonly known as sphingolipids because they contain sphingosine as the alcohol, so they are known as sphingolipids. If they accumulate, then you get the sphingolipidosis. We'll see those questions also. Okay, so you can see the glycerophospholipid. This is the core structure, which is phosphatidic acid, and in front of us you can add something. For example, if you add choline, then it becomes phosphatidylcholine. You can add serine, you can add ethanolamine. Different molecules can be added. Phosphatidylcholine. So when you add choline, it becomes the phosphatidylcholine. It is the most abundant phospholipid of the cell membrane. Common question: most abundant phospholipid of the cell membrane. Answer will be phosphatidylcholine, also known as the lecithin. And one common example is the dipalmitoyl lecithin. You know, some individuals which are born premature infants, there the production has not yet started. It can give rise to the respiratory distress syndrome. So the question is asked: in respiratory distress syndrome, there is deficiency of. Your answer will be the dipalmitoyl lecithin. Your answer will be the dipalmitoyl lecithin. Then we have phosphatidylserine. In place of choline, we have the serine, and this is important because it is the marker of apoptosis. This is the marker of apoptosis. So phosphatidylserine is very important. You should remember this. Then phosphatidylinositol. Here, what is happening? Phosphatidylinositol is a precursor of second messengers. You can get two things: the diacylglycol, commonly written as DAG, and inositol triphosphate, that is IP3. Both of them are second messengers. So phosphatidylnositol, this is a precursor of second messenger. Another important question: which of the following lipids is a precursor of second messenger? Answer will be phosphatidylinositol. And then we have cardiolipin. Cardiolipin is important because it will have the 3 glycerol residues, right? Remember, it has 3 glycerol residues. It is found in mitochondria and it is associated with the condition known as Barth syndrome. So these are 3 important questions from cardiolipin. Has 3 glycerol present in the mitochondrial membrane, and it is responsible for what is known as the Barth syndrome, where the mitochondria is not working properly. Talking about sphingophospholipid, sphingosine attached to fatty acid. This is the common structure ceramide in all sphingolipids. This is the common structure in all sphingolipids. Remember, ceramide is the building block. Just like we had the phosphatidic acid, here we have what is known as the ceramide. And in case of sphingomyelin, which are found in the brain, you can have ceramide plus phosphate plus choline. Okay, so this is the sphingomyelin. The main difference to note is, when you talk about fatty acid, there is only one fatty acid in sphingomyelin. In the phosphatidic acid, we had 2 fatty acid. So keep in mind, in the glycerophospholipid, we have 2 fatty acid, whereas in the sphingophospholipid, we have only 1 fatty acid. This is important. Okay. Moving to question number 27, which of the following is considered a marker of apoptosis when present on the outer leaf layer of cell membrane? We already said the answer is phosphatidylserine. Sialic acid is present in, and here the answer is ganglioside. These are the four subtypes of the glycolipids. In case of cerebroside, you have ceramide plus monosaccharide, right? In sulfatide, you have ceramide plus monosaccharide, which is attached to a sulfate. In globoside, you have ceramide plus oligosaccharide, and in ganglioside, you have ceramide plus oligosaccharide plus sialic acid residue. Commonly, the sialic acid residue is an acetyl neuraminic acid known as NANA. Okay, the number of sialic acid residue is not fixed. You can have 1, 2, 3, or 4. The number of sialic acid residues is variable 1, 2, 3, and 4. Based on that, you can have the GM, GD, GT, and the GQ. Okay, based on the number of sialic acid residues, you can have the GM, GD, GT, and GQ. They can be further separated as GM1, GM2, GM3. The separation is done by electrophoresis. The separation is done by electrophoresis. So here the answer is ganglioside. Ganglioside will have the sialic acid. Depending on the type of ganglioside, you can have 1, 2, 3, or 4 sialic acid residues. Okay, which of the following dietary constituents is not released in the portal vein? Which of the dietary constituents is not released in the portal vein? So normally what happens when you consume food, it is digested, after digestion it is absorbed, and then it is released in the circulation inside the body. Commonly it will go to the portal vein, except for lipids and the lipid soluble vitamins. So where do they go? They go to the lymphatics. Please keep in mind, they will go to the lymphatics. Okay, all others will go to the portal vein. Question 30, very simple, very straightforward. Apolipoprotein integrated in HDL are all except, answer should be B48 and B100. The B series is not there in HDL, otherwise you have all the A series, you have the C series, you have the E series, all of that will be present in the HDL. The B series, B48 and B100 are not present in the HDL. Okay, here quickly take a look at the functions of the apolipoproteins. They can act as activators, also known as cofactors. Okay, C2 for lipoprotein lipase, A1 for lecithin cholesterol cell transferase. They can act as inhibitors, A2 and C3 for lipoprotein lipase, C1 for cholesterol ester transfer protein. Okay. And lastly, they can act as ligand for interaction with the receptors. B100 and E will interact with the LDL receptor. E will also interact with the LRP, and ApoA1 will interact with the HDL receptor. Okay, with the help of these, the different types of lipoproteins can be engulfed by the tissues. So the ligand will attach to the receptor, and then endocytosis will take place. All of the lipoprotein will go inside. Okay, so here the answer was obviously the ApoB48 and ApoB100. Okay, question number 31. Find out the value of LDL if total cholesterol value is 300 mg per deciliter, HDL level is 25 mg per deciliter, triglyceride level is blah blah blah. So here what you have to keep in mind is the Friedewald's formula. According to Friedewald's formula, what happens? The level of LDL is equal to total cholesterol minus HDL plus Tg by 5. The Tg by 5 will actually represent the VLDL. It represents the VLDL. Okay, so total cholesterol minus HDL plus VLDL will give you the LDL value. Okay, it will give you the LDL value. So when you do the calculation, you find out the answer is 245. In other words, what you have to keep in mind that total cholesterol is equal to LDL plus VLDL plus HDL. The amount of IDL is very limited. It is not used for the purpose of calculation. We only say that VLDL plus HDL plus LDL will give us the total cholesterol. Please note that the Friedwald formula has to be used when the value of Tg is less than 400 milligram per deciliter. If the value is more than this, in that case the Friedwald formula will not be used. As long as the value of Tg is less than 400 milligram per deciliter, you can make use of the Friedwald formula. When the value of Tg is more than 400 milligram per deciliter, you cannot make use of the Friedwald's formula. Question 32. Omega-6 fatty acids are all except. Now this is again very important question. Omega-3 and omega-6 fatty acids are commonly being asked in your exam. So you should know which of the essential fatty acids, are belonging to the omega-3 series, which of them are belonging to the omega-6 series. So your options here are linoleic, alpha-linolenic, gamma-linolenic and arachidonic acid. So what I'll do, I'll quickly show you the table having the different types of the fatty acid. Omega-3, we have the alpha-linolenic, the icosapentaenoic acid and the docosahexaenoic acid. Omega-6 has the gamma-linolenic, arachidonic and the linolenic. Very good. These are the non-essential fatty acids. So if you go back to the question, you can make out that the alpha-linolenic is actually omega-3, whereas linoleic, which gets converted to gamma-linolenic, which then gets converted into arachidonic, are all omega-6 fatty acids. Clinical case, question 33. Child presents with hypotonia and seizures. On investigation, the patient is diagnosed to be suffering from Zellweger syndrome, also known as the cerebrohepatorenal syndrome. Please keep this alternate name in mind, the cerebrohepatorenal syndrome, or the Zellweger syndrome. Which of the following will accumulate in the brain? They're asking about brain. For the brain, the answer should be VLCFA. Why? VLCFA is normally metabolized in the peroxisome. In these patients, either the peroxisome is absent or sometimes the structure is there, but it doesn't contain any enzymes. So it is empty. So either the peroxisome is not there or it is empty. In that case, we get the Zellweger syndrome or the cerebrohepatorenal syndrome. The VLCFA are to be metabolized inside the peroxisome. If peroxisome is not working, VLCFA will start accumulating. Most of the VLCFA in our body is present in the CNS. So the accumulation occurs in the CNS. The other tissues have very limited amount of the very long chain fatty acid. So accumulation is also pretty limited. Question 34. On laboratory investigation in a patient, LDL was highly elevated, but the level of LDL receptor was normal. In type 2, what happens? The LDL receptor is having a problem. But here they are saying that LDL receptor is normal. Then which of the following is most probable cause? So now see, LDL receptor has to interact with the ligand. Ligand in this case is B100. So we have to look at B100. Of phosphorylation of LDL receptor, lipoprotein lipase deficiency, B100 mutation. This should be the correct answer. So the receptor has to interact with the ligand. Ligand in this case is B100. So if receptor is okay, then the ligand should have the problem, which in this case is the ApoB100. You can see some of the important inherited hypolipoproteinemias, most important being the ApoA1 and the type 1 and type 2A. Type 1 where you have the lipoprotein lipase deficiency, and type 2 where you have the LDL receptor deficiency. So in type 1, what will happen? The triacylglycerol levels will be elevated, whereas in type 2A the cholesterol levels are greatly elevated. These are two important biochemical aspects you have to remember. In type 2a, the LDL receptor deficiency is there. In type 1, the lipoprotein lipase deficiency is there, because of which the accumulating substances are different. Question number 35, again another clinical case. Chitotriosidase trap ACE enzymes are elevated. The following histopathological picture is seen on bone marrow examination. What is the likely diagnosis? This clinical picture is described as crumpled or wrinkled tissue paper appearance. Crumpled or wrinkled tissue paper appearance. This is known as the Gaucher cell. In which condition do you find the Gaucher cell? The answer is obviously in the Gaucher's disease. Very good, very good. It is found in the Gaucher's disease. So Gaucher cell present in the Gaucher's disease. Okay. So let us quickly take a look at the sphingolipidosis. Here are the important sphingolipidosis. Here you should know about the Gaucher's. Gaucher's is the most common. You should know about Niemann-Pick. Why Niemann-Pick? Why Niemann-Pick? Here the sphingomyelin will accumulate. This is the only condition where sphingomyelin will accumulate. In all others, it is the glycolipid which is accumulating. Except for a Niemann-Pick, the sphingomyelin will accumulate. Okay. Okay, and sphingolipidosis are due to the defect in breakdown. The problem is in the breakdown. Okay, all of them are lysosomal storage disorders. They are autosomal recessive. Exception is Fabry's, which is X-linked recessive. They present with chain spot. Again, exception are Fabry's and Gaucher's. And mental retardation is common, but it is not seen in Fabry's and Gaucher's. Some characteristic findings. What are the characteristic findings? Zebra body inclusion and globoid cell inclusion. See, globoid cell inclusion, globe-like inclusions are there inside the cell. We call them globoid cell inclusions. And the zebra body inclusions, they are seen under the electron microscope. You can see here, they are seen under the electron microscope. And the lysosomal appearance is described as the zebra body inclusion. Watcher's disease, I told you, is the most common. In fact, it is the most common lysosomal storage disorder. The beta glucosidase, the deficient enzyme. Chair red spot mental retardation are not seen. Watcher cell with wrinkled or crumpled tissue per appearance is seen. Presents with abdominal pain and bone pain. Okay, presents with abdominal pain and bone pain. And three things are elevated. In the question you saw chitotriosidase, ACE and TRAP. What is ACE? Angiotensin converting enzyme. What is TRAP? Tartrate resistant acid phosphatase. These are elevated along with chitotriosidase in Gaucher's. Please note, all of these will give you the presumptive diagnosis. The confirmatory diagnosis will come from the genetic analysis. Okay, confirmatory diagnosis will always come from the genetic analysis. Okay, so that is the discussion of part one, the carbohydrate and the lipid part. So you can take a very short 2-minute break. I'll plug in my power source to the laptop, and then we start with part two, that is enzymes, amino acids, and proteins, and heme metabolism. The questions from these topics were included in part two, and we're starting the discussion of part two in 2 minutes. I'll just plug in my power source and then we can start. Okay, let's quickly move on to the part 2 of the paper. Yes, I presume that this video should be available for maybe 24 hours for those who've not been able to join in live. They should be able to access it. And thank you, Dr. Rajat. Okay, so we are moving on to the second paper, which was based on enzymes, amino acids, and proteins, and the heme metabolism. Okay, let's quickly take a look at the questions, the important topics, and thank you, and the associated information that you must know. Some very important information which you have to know from these topics. Okay, just a second. I'll plug in the power source. Okay, okay. So we're moving on to part 2. Now, numerical from enzymes, when it came, it was a surprise for most of us. Even the faculty were very surprised. We did not expect to get numerical from the enzyme. So you can see here, a reaction in which substrate concentration was 1000 times km. After 9 minutes, 1% of substrate is converted to product, which is 12 moles. If the substrate concentration is doubled, enzyme concentration is changed to one third, what would be the time taken to produce the same amount of product? Now this is tricky. You have to understand two things. Number one is what the graph looks like when you look at the velocity against the substrate concentration. If you remember this, then it becomes simpler. Then the story becomes simpler. The graph is something like this. So this graph is divided into three parts. First is a linear part, so it is moving in a straight line. Then there is a curved part, and then you have this plateau phase. This is the plateau phase, means further increase in velocity doesn't occur even if you increase the substrate concentration. This is very important to understand. Means once you're in the plateau phase, no matter how much substrate you keep adding, the velocity will not increase further. So if you already have the concentration of 1000 times km and then you double it, no effect. There will be no effect on the velocity. So first thing to understand is high concentration of substrate, further increase in concentration, no effect. Okay. Second thing what you have to understand is the effect of enzyme concentration. So second thing you have to understand is relationship between the velocity and enzyme concentration. If on the x-axis we have the enzyme concentration, what is the relationship? So this relationship is linear. You keep increasing the enzyme and the velocity will keep increasing. You decrease the enzyme, the velocity will decrease proportionately. Linear relationship means proportionate. So what will happen? Increase in the concentration of substrate, we told you no effect. But enzyme concentration is decreased to one third. So time taken will now be 3 times more. And therefore, the answer in this case is 27 minutes. The answer in this case should be 27 minutes. Previously it was 9 minutes. Now it will be 3 times more and it will become 27 minutes. So factors affecting reaction velocity, substrate concentration, we saw the hyperbolic curve is there. For temperature and pH, we get the bell-shaped curve. I'm sure you know this. If you look at the pH and temperature, we have this optimum pH, optimum temperature, where we get the Vmax. But away from that, there is a sharp decrease. There is sharp decrease, so we get the bell-shaped curve. And for the enzyme, we already said we get the linear curve. Okay, so another very important question: the catalytic efficiency of enzyme is best expressed by which of the following kinetic constant? So here you have to remember the catalytic efficiency is described using the formula kcat by km. They've even given a numerical from this, which we don't have in this test, but a numerical has been asked based on the kcat by km, which is describing the catalytic efficiency. Okay, question 3, another very important and commonly asked question. Based on the graph, we have to identify the type of inhibition which is occurring. So you can see here the red line is showing the graph where inhibitor is present, and the green or blue depending on the screen, this is the normal uninhibited reaction. Okay, and the various options are competitive, non-competitive, allosteric, and the uncompetitive. I'll quickly show you the three different graphs: the competitive inhibition, the uncompetitive inhibition, and the non-competitive inhibition. Now, it can become very difficult and confusing to find out what type of inhibition occurs in which cases and what is the appearance of the graph. So I'll give you a very simple trick. The Vmax is normal. You remember Vmax is normal in competitive inhibition. The Km is normal. The Km is normal in non-competitive inhibition just by definition. So if you remember only these two things, Vmax normal in competitive, Km is normal in non-competitive, then your work will become simple. Why? Because these 2 points can be seen on the graph, where the graph crosses the y-axis. This is 1 upon Vmax. Where the graph crosses the x-axis, this is minus 1 by Km. So if the Vmax is same, 1 by Vmax will also be same. If the Km is same, minus 1 by Km will also be the same. So if the 2 points are same, minus 1 by Km is same, means Km is same. Km is same in non-competitive. If 1 by Vmax is same, then Vmax is also same. Vmax is same in competitive inhibition. So if you remember where the normal values are there, then you can quickly identify the graph. So here you can see the Vmax is the same. Vmax is same in competitive inhibition. Vmax is same in competitive inhibition. So just by remembering what is normal, you can quickly identify the graph. Now, another time this question was asked where they did not ask you to identify the type of inhibition. Rather, they gave you a list of drugs, and there they ask which of the following drugs is inhibited by the mechanism shown in the graph. So when you're revising your drugs, please make sure you are very clear, you are familiar with the type of inhibition that is happening as a result of that particular drug. So spend a few seconds and build that relationship between the type of graph and the action of the drug. Okay, very important. Okay, paint factory worker working since 20 years came with complaints of joint pain, insomnia, fatigue, constipation, headache, found to have anemia. Which enzyme is affected? So here you have to remember the 3 P's. You have to remember the 3 P's. What are the 3 P's? 3 P's are paint, pipe, and petrol. Nowadays petrol is out of this list, but paint, pipe, and petrol are the 3 important, historically important sources for lead. So when the question says paint factory worker, immediately you should think about lead. So we're talking about lead inhibition, and the important finding is anemia. So lead is preventing the iron synthesis or the heme synthesis at 2 steps. More important being the ferrochelatase. It also inhibits the ala dehydratase. So these are the 2 enzymes in the heme synthesis which are inhibited by lead. So here the answer is ferrochelatase, also known as the heme synthase. Ferrochelatase, also known as heme synthase. Second enzyme will be the ala dehydratase. Question number 5. Flipped pattern of LDH is seen in myocardial infarction. Which of the following is the flipped LDH pattern? So here you have to remember that LDH type 2 is most common, LDH type 2 is most common. So normally what will happen? Normally what will happen? The type 1 should be less than type 2. Normally type 1, type 1 should be less than type 2. But in myocardial infarction, the LDH type 1 is coming out in large amounts because it is produced by the heart. So in that case, what will happen? Now the type 1 will become greater than type 2. Okay. So what will happen? The ratio has flipped. Previously 1 was less, now 1 is more. This is called the flipped LDH ratio. So obviously LDH1 greater than LDH2 is the flipped LDH ratio. This will be seen in myocardial infarction. Which substance increases nitrogen excretion in urea cycle disorder? Again, very important, commonly asked question. Urea cycle disorders are a hot favorite of the examiners. So here you have to remember the answer is normally, commonly the students will mark phenylbutyrate. But what you have to remember that phenylbutyrate is actually a prodrug. So the medicine which is given is the phenylbutyrate. But this phenylbutyrate will get converted into the phenyl acetate. And then this phenyl acetate will combine with the glutamine to give us phenyl acetyl glutamine. So the product which is excreted is the phenylacetyl glutamine. Okay, phenyl acetate is the molecule which is interact with glutamine, and the precursor or the prodrug is the phenylbutyrate. So here the correct answer is not phenylbutyrate but the phenyl acetate. Phenyl acetate increases nitrogen excretion. It is generated from phenylbutyrate which is given to the patient. Okay. So another molecule which can be given in urea cycle disorders are benzoate. Commonly it is given at sodium benzoate. Sodium benzoate. Here the benzoate will combine with the glycine and it generates the hippuric acid. Hippuric acid as well as the phenylacetyl glutamine. Both of them are excreted in the urine. In addition, arginine can be given. Arginine can be given for deficiency of enzyme 3 and 4, and N-carbamyl glutamate can be given when there is deficiency of the N-acetyl glutamate. Okay, right. Clinical case. 2-year-old male child presents with pellagra-like lesions with passage of amino acid in urine. Family in the family out of 4 siblings, 2 are having similar symptoms with 2 normal siblings. Parents are not affected. If parents are not affected, this is likely to be the recessive condition. If parents are not affected, it's likely to be the recessive condition. Otherwise, it would be the dominant condition. So what we can see out of 4, 2 are having the similar symptoms. So again, it would be likely to be the recessive. And here amino acids are being passed, presents at pellagra. Pellagra is due to deficiency of niacin. Niacin is formed from which amino acid? Answer is tryptophan. Tryptophan is lost in the urine in Hartnupp's disease. Tryptophan is lost in the urine in Hartnup disease. So here the answer should be the Hartnupp's disease. Coming back to enzymes, all the following are examples of irreversible inhibitors except, so I'm sure if you know, malonate on succinate dehydrogenase is the competitive inhibition. This is not an irreversible inhibition. This is a competitive inhibition. Malonate on succinate dehydrogenase. The others are example of irreversible inhibition. So these are some of the irreversible inhibitions. The group specific reagent, reactive substrate analogs, and the suicide inhibitors. You can see here dimethyl propyrogylamine acting on monoamine oxidase, penicillin acting on glycopeptide transpeptidase, allopurinol acting on xanthine oxidase. Other examples include the NSAIDs and the pifluorouracil on the thymidylate synthase. These are some of the other examples. Okay. A patient admitted to ICU with acute myocardial infarction suffers a second attack on the fourth day. Which of the following should be used to confirm the diagnosis? Now you can see there are some confusing options. First option is spot test for troponin T or I, isolated CPK-MB values, LDH isoenzyme ratios, and serial values of troponin T and I. You can see two very conflicting options. One is spot test and second is the serial value of troponin T and I. Please note, traditionally we would mark the option of CPK-MB values. Why? This is a case of reinfarct. In reinfarction, the kit of the troponin TI is not very useful, because even if MI is not there, this kit will give us the positive result, right? So it is not very useful. But the serial values of troponin, they will show a rising trend. They will show a rising trend for up to 24 hours, even 36 hours. So now it becomes very useful. Because of the rising trend, the troponin T or I tests will help us in diagnosis. So if the troponin values are available, then the American Heart Association says that okay, we should do the serial values and you should look for rising trend. If the rising trend is there, then you're looking at reinfarction. However, if the exact value of troponin is not available, in that case you go for the isolated CPK value, which it can be done on a semi autoanalyzer also if it is readily available. Best test for MI is the troponin T or I, but it is not routinely used for reinfarct. Okay, because even if the infarction is not there, this test will come out as positive. Moving on to the amino acid, indole ring is present in, your options are arginine, histidine, tyrosine, tryptophan. In arginine, the ring structure is not there, but what we have is the guanidino side chain. In histidine, we have the ring structure, which is the imidazole ring. In tyrosine, we have the indole ring. In we have the phenol ring. In tyrosine, we have the phenol ring, and tryptophan will have the indole ring. Here you can also add phenylalanine. Phenylalanine, which is going to have the benzene ring. Okay, so as you can make out, histidine, tyrosine, tryptophan, and phenylalanine, these are aromatic amino acids. They have the ring structure in the side chain, and each of the ring structures are named. So imidazole, phenol, indole, and the benzene ring are there. Please note, guanidino side chain is not a ring structure. It is not a ring structure. Okay, question number 11. O glycosylation, addition of sugar, change can happen on hydroxyl oxygen on the side chain of all except, answer should be asparagine. Here we have N glycosylation. All others will show the O glycosylation and asparagine will show the N glycosylation. These are the only 4 amino acids where the glycosylation can take place. 3 of them will show the O glycosylation, 1 of them will show the N glycosylation. Other amino acids are not receptive. Other amino acids are not receptive for the glycosylation. Okay. There's some issue with the connectivity. Just give me 1 second. I'll check the connectivity again. Okay, okay, so looks stable now. Okay, moving on to question number 12. Moving on to question number 12. Selenium is present in all except. Now here what you have to understand, selenium is present as the 21st amino acid. It is present as the 21st amino acid, which is selenocysteine. It is present as the 21st amino acid, selenocysteine. It is present in the glutathione peroxidase. It is present in the G6PD. It is present in the deiodinase, but not in the glutathione reductase. Okay, so it is present in the selenocysteine. It is present in the glutathione peroxidase, G6PD, and the deiodinase. Another enzyme where it may be present is thioredoxin reductase. It is also present in the enzyme thioredoxin reductase. Because it is the 21st amino acid, a lot of questions will come on this. You have to remember the name of the important enzymes where it is present in the active site. Okay, which amino acid does not show post-translational modification? So there is a follow-up question from there, and the answer is selenocysteine. Why? Because selenocysteine is inserted during the translation. There is co-translational insertion. When you talk about selenocysteine, the term you have to remember is the co-translational insertion. It is not a result of the post-translational modification. It is not a result of the post-translational modification, rather it is the co-translational insertion. All others are the result of modification later on. Question 14. Isoelectric focusing, also known as electrofocusing, is a technique for separating different molecules by differences in their isoelectric pH. Isoelectric pH. Okay, so the separation is by isoelectric pH. Please keep this in mind. The answer is isoelectric pH. Okay, isoelectric pH is written as pi. So isoelectric focusing is based on the differences in isoelectric pH. This is a follow-up question from isoelectric pH. So when you have a very big cluster of proteins and you want to separate it, for example, you have taken the cell lysate from maybe a culture or some tissue, and you want to separate out all the proteins. So single separation technique is not enough. We commonly do two techniques, one after the other. So this is one such example where we have first done the isoelectric focusing followed by the SDS page. This is known as the two-dimensional electrophoresis. This is the 2DE, known as two-dimensional electrophoresis. So isoelectric focusing followed by the SDS page. Okay, so common techniques for the separation of proteins on the basis of solubility. Old method, not used nowadays, but on the basis of molecular size, still being used clinically for dialysis, gel filtration chromatography, and ultracertification. Gel filtration chromatography is also known as the size exclusion chromatography. It is also known as the size exclusion chromatography. Then we have on the basis of molecular charge. This is the more commonly used method for separation of protein. Basically different types of the electrophoresis. All of this will come under the separation of protein on the basis of charge. And when you want the very pure protein, in other words we call it the ultra pure proteins. When you call the ultra pure proteins, in that case we use the separation based on affinity binding. We use the separation based on affinity binding. Okay, so here we have two properties which can be used. One is the affinity chromatography, and second is precipitation by antibodies. In these cases, you are going to get the ultra pure form of the protein. Moving on to question 16, Guthrie test. Guthrie test is positive. You know it is positive in the phenylketonuria. So we are talking about a patient of the phenylketonuria. So which of the following is not true? Your deficiency in phenylalanine is true. Phenyl acetate present in urine? True. Mental retardation is present? True. White patch of hair due to tryptophan deficiency is not related to PKU. Phenyl acetate, which is present in urine, is responsible for mousy odor. Sometimes instead of mousy, the question will say musty odor. So mousy or musty odor. So here the answer would be due to phenyl acetate. Okay, so in PKU, the white patch of hair due to tryptophan deficiency is the unrelated statement. This is not true. In phenylketonuria, the main aim of first line therapy. So first you have to know what is the main first line therapy. First line therapy is the dietary restriction. Why do you want to do the dietary restriction? Because phenylalanine will accumulate. It will give rise to the phenyl lactate, phenyl pyruvate, phenyl acetate, which causes the mental retardation. So we want to decrease the phenylalanine so that the abnormal metabolites are not formed. So what we are doing, we are reducing the substrate. We are reducing the substrate for the formation of the abnormal metabolites by the specific enzymes. So let us take a quick look at some of the disorders associated with the phenylalanine metabolism. Phenylalanine converted to tyrosine. This is the PKU, specifically PKU. And here the enzyme which is deficient is phenylalanine hydroxylase, giving rise to phenylketonuria. The coenzyme is also required. The tetrahydrobiopterin is the coenzyme which is required. If there is problem with the coenzyme, then also you can have the PKU. If the recycling is not taking place, if the synthesis is not taking place, then also you can have the PKU. These are done because once the mental retardation has occurred, once the mental retardation has occurred, the subsequent recovery of that retardation is not happening. So we have the fluctuating connectivity, because of which sometimes lose the screen share. Just a second. Connectivity issues. I'm losing the screen again and again. Okay. Okay, I'm sorry for the connectivity issue. We have changed the uh, network, so hopefully it should be better now. We are talking about the PKU, and we discussed the different types of the PKU, whether it be to enzyme deficiency or the coenzyme deficiency. Okay, so subsequently, with the tyrosine metabolism, tyrosine gets converted to the hydroxyphenyl pyruvate, and if the tyrosine aminotransfer is deficient, then we get the tyrosinemia, which is the type 2 tyrosinemia. The hydroxyphenyl pyruvate further gets metabolized to homogenticide by the enzyme hydroxyphenyl pyruvate oxidase. Deficiency causes the neonatal tyrosinemia. Sometimes the hydroxyphenyl pyruvate enzyme is there, oxidase enzyme is there, but it is defective. In this case, the condition that we get is Hawkinsinuria rather than the neonatal tyrosinemia. We get the Hawkinsinuria. The neonatal tyrosinemia is also known as tyrosinemia type 3. The homogenticide is further metabolized to phenyl acetate by the homogenticide oxidase. Deficiency causes L-captonuria. Deficiency causes L-captonuria. And lastly, phenyl acetate getting converted to fumarate plus acetoacetate by the enzyme phenyl acetate hydrolase. Deficiency causes tyrosinemia type 1, also known as tyrosinosis. Also known as tyrosinosis. So these are some of the important enzymes and the different types of tyrosinemia and alkaptonuria associated with the phenylalanine-tyrosine metabolism. So names we should know. So you can see question on tyrosinosis. When this question was asked, a lot of students did not know that tyrosinosis is the other name for tyrosinemia type 1, and we just mentioned deficient enzyme is fumarate acetoacetate hydrolase. Fumarate acetoacetate hydrolase is the deficient enzyme in tyrosinosis. Okay. Question number 19, again talking about the inborn errors of amino acid. Which of the following urinary odors is not correctly matched? So we commonly get question on the urinary odor and which clinical condition it is seen. So you know, sweaty feet odor, isolatic acidemia is correct. Mousy musty odor, phenylketonuria, we just mentioned, this is correct. Burnt sugar odor in maple syrup urine, this is also correct. Swimming pool odor is seen in the condition we just mentioned, that is Hawkinsinuria. Whereas in tyrosinemia, what we get to see is the boiled cabbage odor. Boiled cabbage odor is seen in tyrosinemia. Okay. So quick look at some of the other conditions you should know. We already mentioned sweaty feet, mousy musty odor, burnt sugar, sweaty or fruity odor. This is hallmark of ketoacidosis. Fruity odor in the urine as well as the breath, that will be in the ketoacidosis. We already mentioned swimming pool odor. Sulfur odor is seen in the suppurative disease of the genitourinary tract or in the cystine decomposition. And ammoniacal odor is particularly seen in bacterial infection or when there is retention of urine in the bladder. Okay. Fecal odor will be in case of bladder intestinal fistula. This is common. Or when there is malingering, when the contamination of feces by the patient is done, this is malingering. In that case, we can have that. Faintly aromatic, this can be in the concentrated urinary samples. And drugs and diet, characteristic odor of lot of drugs. Moving on to next question. Glutathione does all of the following except participate in transport of amino acid across cell membrane. This is true. This is known as the Meester cycle. Scavenges peroxides. This is also true. Forms conjugate with some drugs to increase water solubility. This is also correct. By the enzyme glutathione S transferase known as the GST. It increases the stability of RBC membrane rather than decreasing. So glutathione does not decrease, it increases the stability of the erythrocyte membrane by again the scavenging of the peroxides. It will increase the stability and not decrease. Okay. The formation of conjugate with some drugs to increase water solubility is done by the glutathione S transferase. This is a very important xenobiotic metabolism. About 8 different families of this enzyme are present in our body, having a lot of the polymorphic variants. Okay, moving to question 21. I just told you Mr. cycle is used for transport of amino acid, and here the enzyme which is involved is the gamma-glutamyl transpeptidase. Gamma-glutamyl transpeptidase is a part of the Mr. cycle involved in transport of amino acid across the membranes. Question 22. Type of collagen found in wound at day 5 of the healing. What you have to understand, in the first 3 to 4 weeks, the wound is brought closer together. So flexible collagen type is formed, which is the type 3. By the end of 4th week, then the strength of the collagen starts increasing. So the type 1 will appear after 4 weeks, not days. If it were week 5, then answer would be type 1. Okay, but day 5 the answer will be type 3. Please keep this in mind. If it is day 5, then answer is type 3, but it is week 5, then answer will be type 1. So type 1 starts coming at the end of 3rd or 4th week, and gradually it will start replacing the collagen type 3, and the collagen type 1 will become predominant. The deposition can continue up till 1 year. Okay, so deposition will keep occurring for a long duration up till 1 year. Question 23. Auxiliary proteins assisting in folding include all except heat shock protein, chaperonins, calnexin. All of them are correct. Ubiquitin is not involved in folding of the proteins. So some examples of proteins which assist in folding: the chaperones, including the chaperonins and the heat shock proteins, the protein disulfide isomerase, the proline cis trans isomerase, the calnexin, calreticulin, the GRP94, and the BIP. Okay, so these are some of the important proteins which assist in folding. Obviously there are more proteins, but these are some of the common proteins which assist in folding. Defective protein in Marfan syndrome. Very commonly we tend to mark collagen, which is not the correct answer. The correct answer is fibrillin, and that too fibrillin type 1. Fibrillin type 1 is defective in the Marfan syndrome. Please keep in mind fibrillin type 2 can also be found to be defective or deficient, giving rise to the condition called congenital congenital contractural arachnodactyly. It gives rise to the condition known as congenital contractural arachnodactyly. Okay, so in Marfan syndrome, defective protein is fibrillin type 1. Fibrillin type 1 is the defective protein in the Marfan syndrome. Question 25. Most suitable test for screening of metabolic disease. The answer here should be tandem mass spectrometry. Up to 40 different diseases can be identified using one dried blood draw. So highly efficient. A very small amount of sample is required for the screening of metabolic disease when you use the tandem mass spectrometry. For others, you have to invest a lot of cost, a lot of energy, a lot of time is required to interpret using the different techniques. You cannot have a common process for the large number of diseases. Okay, so here the answer is tandem mass spectrometry. For electrophoresis, you will have to have the antibodies for each of the diseases for which you want to do the screening, not so for the tandem mass spectrometry. Histidine is produced by which of the following chemical reactions? So you have to remember the decarboxylation will give rise to histidine as well as GABA. So instead of histidine, if the question says GABA, then also the answer will be the decarboxylation. Decarboxylation gives rise to histidine and the GABA. Quite frequently asked, multiple times this question has been asked. Okay. A girl with habit of eating paint. Again, see, again the question of paint has come. Previously it was the factory worker in the he was working in the paint factory. Now here a habit of eating paint peeler from wall present complaint of acute abdominal pain on and off with tingling sensation of limb associated with weakness of the limb. Which of the following enzyme will show reduced activity in this enzyme? So here in this case, please note the answer is aldehyde because the ferrochelatase or the heme synthase is not given. I told you two enzymes, the ferrochelatase or the heme synthase and aldehyde. So here the answer will be aldehyde. In the previous question, the answer was the heme synthase, right? Question number 28. Heme breakdown produces ferric ion, carbon monoxide and biliverdin. Carbon dioxide is not produced. Okay, carbon dioxide is not produced. So the reaction is something like this. Heme is converted into biliverdin. Along with this, the Fe3 plus is released. Oxygen will go in, but what you get is carbon monoxide. What you get is carbon monoxide. Okay, carbon dioxide is not produced, it is the carbon monoxide. So for every molecule of heme you get one molecule of biliverdin. This is another question which is asked. Equimolar release of biliverdin is seen for the heme. Very good. Okay, moving on to question number 29. You can see very severe jaundice is there in this patient. Patient presents to OPD with well-developed jaundice along with other symptoms. On detailed examination investigation, the patient is provisionally diagnosed to be suffering from carcinoma of head of pancreas. Which of the following is not true? Carcinoma head of pancreas means we are looking at obstructive jaundice. Obstructive jaundice means in the blood, conjugated bilirubin will be elevated. Increased conjugated bilirubin in the blood. What you remember, the conjugated bilirubin is water soluble, so it will appear in the urine also. So now let's look at the options. Decreased urobilinogen in urine is correct because it is not going into the intestine. It will not get converted to urobilinogen. It will not appear in the urine. Okay. Dark yellow mustard color urine is correct. Pale or clay colored stool is correct. Decreased bilirubin in urine is not correct. It will appear in the urine which is imparting the yellow or the mustard color to the urine. So the option should have been increased bilirubin in urine, not the decreased bilirubin in urine. Okay. Dark yellow or mustard colored urine is available, is there because of the decreased excretion, increased excretion in the urine. Okay, so in obstructive jaundice, what do you find? Dark yellow or mustard colored urine along with pale or the clay colored stool. These are the two hallmarks. These are the two hallmarks of obstructive jaundice: pale or clay colored stool and dark yellow or mustard colored urine. The two hallmarks of obstructive jaundice. Okay. Which of the following is not a finding of acute intermittent porphyria? Now this is a trick question because normally porphyria will present, if you talk only about porphyrias, they have a cluster of three symptoms: abdominal pain, photosensitivity and the neuropsychiatric complaints. Okay, and during the episode the Ehrlich aldehyde test will be positive. So what is the problem here? Here we are talking about the acute intermittent porphyria. In acute intermittent porphyria, what you have to keep in mind, a ring structure has not yet been formed. The ring structure has not yet been formed. Because the ring structure has not yet been formed, the photosensitivity will not be there. The only porphyria, photosensitivity is not there. All the other porphyrias, the photosensitivity will be there except for the acute intermittent porphyria. In acute intermittent porphyria, the photosensitivity will not be there. So keep this in mind. Photosensitivity is absent in acute intermittent porphyria. It will be absent in acute intermittent porphyria. Question 31. Which of the following is a conformational disorder? Conformational disorder means primary structure or the first order organization is okay, but second, third, or fourth order are not okay. Okay, so if first order structure is okay but second, third, fourth order structure is not okay, then we call it the conformational disorder, and here the answer is prion disease. Others will include the scurvy and Alzheimer's. These are other examples of the conformational disorder. The prion disease, scurvy, Alzheimer's, these are other examples of conformational disorder. In the other conditions, B, C, and D, the protein structure is getting affected, but the primary structure may also be defective there. Or in case of good posture syndrome, there is the cross reactivity, the abnormal immune response is there. Question 32. Which of the following enzyme does not contain zinc? So here you have to remember aconitase will contain iron. It doesn't contain the zinc. All the other three enzymes are containing the zinc. So answer is aconitase. Aconitase, an enzyme of the Krebs cycle, is containing iron. It doesn't contain zinc. The other three contain zinc. Other three contain zinc. Okay. Question number 33. An adult presents with complaints of urine turning black on standing. What is the enzyme which is deficient? So obviously this is a case of alkaptonuria, and the deficient enzyme is the homogentisate oxidase. We had seen all the enzymes and the disorders previously. So this is a case of homogentisate oxidase deficiency. Question 34. Patient presents with unconjugated hyperbilirubinemia but doesn't have anemia, is most likely suffering from. So here what is happening? There is defect in the bilirubin metabolism and unconjugated hyperbilirubinemia is there. So let's look at the disorders. In this case, you should have the conjugated bilirubin. Dubin, Johnson and Roter will have conjugated bilirubin. Only Gilbert's among the list will have the unconjugated bilirubin. Okay, Gilbert's and the Crigler-Najjar syndrome and the Gilbert syndrome, they will give you the unconjugated bilirubin, whereas in the Rotor syndrome, Dubin-Johnson syndrome, you will have the conjugated bilirubin. The carcinoma head of pancreas you already seen, where we saw the conjugated bilirubin will be there. Please note all these conditions are inherited, right? All these conditions are inherited. Question 35. DNA protein interaction can be studied using. When this question was asked, nobody knew the answer. So everyone marked something else, but nobody was sure about the answer. Here you have to remember it is the DNA footprinting. Okay, DNA fingerprinting is to establish the relationship, or you can say to establish the identity. Northern blotting is for RNA. ELISA is for protein. ELISA is for protein, whereas DNA footprinting is for the DNA protein interaction. In this context, I'll give you a very simple and easy to remember mnemonic for the different types of blotting techniques. So you can see southern blotting, northern blotting, western blotting. So southern blotting for DNA, northern blotting for RNA, and western blotting is for protein. So snowdrop is a mnemonic how to remember the different blotting techniques and for which molecule they are going to be used. So the answer is snowdrop. Southern for DNA, northern is for RNA, western is for protein. Okay. Very good. So this brings us to the end of the second test, where we talked about the enzymes, the amino acid protein, and the heme metabolism. The third test is the one where we talked about molecular biology, vitamins, and a little bit about the minerals. Okay, so let us move on to part 3, the test 3 that we did, where we talked about these specific molecules. Okay, battery. Let me put it in charging. 1 minute. Let's start the third part of our discussion. Okay, so as you must have seen in this series, there are a lot of clinical cases coming from the vitamins. Vitamin has become a very high topic for our exam in the last 2 3 years. Every year we are getting anywhere between 4 to 8 questions only from the vitamins. So we'll try to see as much as possible related to the vitamins how to approach these questions. Okay, question number one: 56-year-old homeless man presents to emergency room with increased fatigability and exertional dyspnea. Physical examination shows significant lower extremity edema and decreased sensation over ankles and feet. Further evaluation reveals cardiac dilation and increased cardiac output. So, two things you are seeing here. One is the features of heart failure, congestive heart failure. Okay, and along with that, we are finding the increased cardiac output. So high output cardiac failure is a characteristic of the thiamine deficiency. This is the wet beriberi, what is known as the wet beriberi. High output cardiac failure. High output cardiac failure. This is the wet beriberi. Okay. So let's quickly take a look at the thiamine. What are the points you have to know about thiamine? Number one, the RDA. RDA is very unique for thiamine because it is not in terms of body weight, rather in terms of the energy consumption. You can see here it is described in terms of the energy consumption, 0.5 milligram per 1000 kilocalorie of the energy intake. Same for riboflavin also. The same thing will happen for riboflavin also. Just give me a second. lot of connectivity issues today. Okay, I hope this is better now. Okay, then deficiency of thiamine is monitored using the enzyme erythrocyte transketolase. Using the enzyme erythrocyte transketolase, we are able to monitor the deficiency. And various enzymes where the thiamine is required, the PDH, the Krebs cycle, the HMP shunt, and in the metabolism of branched amino acid for acetylcholine formation. Deficiency will cause beriberi and Wernicke encephalopathy. Deficiency will cause beriberi and Wernicke encephalopathy. When you talk about beriberi, you can have the dry beriberi and the wet beriberi. In the dry beriberi, what is happening? We have the involvement of the CNS, right? So, main finding is the paresthesia. Whereas in wet beriberi, we have the main finding of high output cardiac failure. High output cardiac failure is the main finding. Okay. And then we have the Wernicke's encephalopathy. In Wernicke encephalopathy, which is commonly seen in chronic alcoholics, we have the global confusion of thalmoplegia. And if psychosis is present, we call it Wernicke-Korsakoff psychosis. Okay, those who have joined late, I'd just like to say that we are doing the discussion of all the three tests together. Now we are at paper 3. Paper 1 and 2 have already been discussed. So this video will be available for some time on YouTube, I hope. And you should be able to see the discussion in the first initial half of the video, the paper 1, then paper 2, and now we are at paper 3. Question 1 of paper 3 is being discussed. Okay, moving on to question 2. An old lady living alone presented with tingling sensation in legs and hands. On examination, she has fissured tongue and lesions in the angle of mouth. On investigation, she had decreased erythrocyte glutathione reductase activity, characteristic of which is following vitamins is likely to be deficient. Here, the answer is vitamin B2. In B1, we had the transketolase activity. For B2, we have the glutathione reductase activity. So these two can be used to identify the deficiencies. Let's look at B2 riboflavin. Uh, A riboflavinosis. Deficiency causes A riboflavinosis. So here you have painful red tongue, fissured lips, and the inflammation of the corner of mouth is called angular stomatitis. These patients will also have anemia, and the appearance of stomatitis is similar to that we see in the pellagra. So in pellagra also we have stomatitis, here also we have stomatitis. Both of them have similar presentation. Okay, so painful red tongue with sore throat, chapped and fissured lips, and inflammation of the corner of the mouth. Casal collar, Casal necklace is being asked again and again. You can see a very thick pigmented area in the dermatomal distribution of C3 and C4, and this is due to deficiency of vitamin B3, that is niacin. In the niacin deficiency, we have the Casal collar, Casal necklace. Thiamine is a cofactor for all the following enzymes except the alpha-ketoglutarate dehydrogenase, the branch-chain ketoside dehydrogenase, the pyruvate dehydrogenase, succinate dehydrogenase. Here the answer is succinate dehydrogenase. For succinate dehydrogenase, the coenzyme is riboflavin in the form of the FAD. It is the coenzyme for the succinate dehydrogenase. The others will make use of thiamine. A child with tingling of hands, pallor, and ataxia. Okay, so tingling of hand and ataxia, these are neurological findings. Pallor is due to the anemia, right? So two things, neurological deficit and anemia, both of them are there. This means we are looking at B12 deficiency, right? We are looking at the B12 deficiency, means we are looking at the cobalamin deficiency. Okay, so here you have to keep in mind the urinary finding in cobalamin deficiency is methyl malonic aciduria. methyl malonic aciduria is characteristic in B12 deficiency. Another important thing that we see in B12 deficiency is what is known as folate trap. So B12 directly is not involved in heme synthesis, but it traps the B9, because of which the heme maturation etc. is not occurring successfully. So it will block the folate, and that is causing the anemia. So the anemia in B9 deficiency and B12 deficiency will be the same. What type of anemia will be there? The nature of anemia is megaloblastic anemia. The nature of the anemia is megaloblastic anemia. Okay. Another thing which you have to remember in the B12 is, in B12 what you have to remember additionally is three parts of the digestive system have to be intact. If there is any problem in any of these three parts, then the absorption of B12 will get affected. First is oral mucosa. Second is gastric mucosa. And third is ileum. If any of these three are not working properly, then absorption of the B12 will get affected. The oral mucosa will give you cobalamin. The gastric mucosa will give you the intrinsic factor, and ileum is where the final absorption will take place. So if there is any damage in the oral mucosa, suppose oral mucosa is not causing the secretion, the cobalamin will not be released. If the gastric mucosa is not working, atrophic gastritis is there, again the intrinsic factor will not be released. And because of any reason you remove the ileum, let's say there is a penetrating abdominal trauma where the ileum and the jejunum have to be resected. In that case, again the absorption of the B12 will not take place. These have been asked as clinical case. Each of the three conditions have been asked as a clinical case. You should know. Atrophic gastritis, condition like keratoconjunctivitis sicca where the oral secretion is minimized, and any post-op condition where the ileum has been removed, absorption of B12 will get affected. Okay, moving on to question number 6. You can see here in the picture there is a layer on the cornea. This is the eye dot spot, and this is deficiency of vitamin A. Vitamin A deficiency is very important for our exam. Lots of questions will come from the vitamin A deficiency. Remember here that the beta carotene is not vitamin A. Please remember, beta carotene is not vitamin A. Then what is beta carotene? It is just the precursor. It doesn't have the vitamin A activity. Because of this reason, please note, because although beta carotene is antioxidant, vitamin A cannot be said to be antioxidant. Okay, vitamin A is not an antioxidant. Beta carotene is antioxidant, but not vitamin A. Please keep this point in mind that vitamin A is not antioxidant. It is beta carotene, which is the precursor form, which is the antioxidant. Very important role of vitamin A is in the visual cycle, and a very important clinical condition due to toxicity is the pseudo tumor cerebri. When the vitamin toxicity is there, the condition will mimic the presence of a tumor in the cerebrum, so it is known as a pseudo tumor cerebri. So these are additional points which you have to remember in case of the vitamin A. Which enzyme required for vitamin C synthesis is missing in the humans? The answer is gulonolactone oxidase, also missing in bats and the guinea pig. Missing in bats and the guinea pig. So question asks which of the following organisms do not require vitamin C. So here you remember humans, bats, guinea pigs, they will require vitamin C. Any other organism which is there in the option, for that you can choose. They will not require the vitamin C in the diet. Okay, active form of vitamin C is ascorbic acid. Main function of ascorbate is reducing agent in several different reactions. Deficiency of ascorbic acid will cause scurvy. Okay, you already know this. Synthesized in all mammals except primates, guinea pigs, and also bats. Vitamin that helps in absorption of iron. What should be the answer here? Here answer is vitamin C. Let's take a quick look. What is happening? The absorption of iron occurs in the ferrous form. So the ferric iron has to be reduced. So reducing agent is required. So vitamin C is very helpful in this reduction. We also have specific enzymes which can carry out this reduction, but any reducing substance will help. That is why when you give the iron supplement, along with that either you give juices or you give supplements where vitamin C is already there inside the supplement to facilitate the absorption of the iron in the ferrous form. Please note that the heme iron is getting absorbed by a separate mechanism. It is not getting transported by the divalent metal transporter. Divalent metal transporter is written as DMT. It will also carry out the absorption of calcium, zinc. So there's a lot of competition at the level of DMT for absorption of iron. Limited iron can get absorbed. Okay, so subsequently you can see that this ferrous iron is is retained in the mucosa. Depending on activity of ferroportin, only the iron will be secreted. This ferroportin in turn is regulated by the hepcidin. So when hepcidin is more less ferroportin activity, less iron is getting into the bloodstream. So this is how the body will control the entry of iron inside the body. Limited amount of oral iron can enter inside the body. That is why when you want to increase the body stores of iron quickly, you have to give the injectable form. Oral form is not enough because it is not possible that you give a large amount of iron and suddenly the absorption will increase. No, a limited amount of absorption only can occur. Okay, so this is a protective mechanism because iron is responsible for reactive oxygen species by the mechanism of what is known as the Fenton reaction. That is why, if you recall, in the first trimester, when there is a lot of risk of reactive oxygen species causing damage to the uh, embryo, at that time iron supplements are not given in the first trimester. They are given only when the organogenesis is completed in the second trimester onward. So the protective mechanism in the body limits the amount of iron which is entering inside the blood. Vitamin K is needed by which enzyme? Here the answer is vitamin K epoxide reductase. Okay, vitamin K epoxide reductase will require vitamin K. Now this is a very important and tricky question. In adults, a severe deficiency of vitamin D causes which of the following disorders? So please note the answer is osteomalacia. It is not osteoporosis. So answer is osteomalacia. Rickets is what will be seen in the children. In case of vitamin D deficiency, we see rickets in the children. Question 11. What is the nature of bond between the two nitrogen bases on opposite strand and double strand DNA? The answer here is hydrogen bond. Answer is hydrogen bond. The beta and glycosidic bond is seen between the nitrogenous base and sugar. The 3' to 5' phosphodiester bond is seen between the two sugars. The phosphodiester bond 5' to 3' doesn't exist. We have the 3' to 5' phosphodiester bond. Okay. Question number 12. Which of the following is not a constitutive heterochromatin? So very quickly I'll show you how the chromatin is described so that we can quickly remember about the chromatin. So you talk about chromatin, you will have the euchromatin and you will have the heterochromatin. Okay, euchromatin and heterochromatin. The heterochromatin can be facultative or it can be constitutive. Facultative or constitutive. The constitutive type may be microsatellites or they may be satellites. And the satellites include the telomere and the centromere. They include the telomere and the centromere. So now the question is talking about the constitutive heterochromatin. So constitutive heterochromatin are microsatellites, telomeres, centromere, satellites. So centromere, telomere, satellite, all of these are constitutive heterochromatin. The answer is bar body. Bar body is a type of facultative heterochromatin. It is a type of the facultative heterochromatin. Okay. So answer here is the bar body. The answer here is the bar body. Okay. In SCID, what type of DNA repair is defective? So here you have to remember it is the non-homologous end joining. Take a look here. In mismatch repair, the hereditary non-polyposis colony carcinoma is there if the repair mechanism is not working. If the base section repair is not working, then we get the MAP, which is a type of the FAP. If the nucleotide exchange repair is not working, in that case you get the xeroderma pigmentosum, the Cockayne syndrome, the trichothiodystrophy. If the homologous repair is not working, in that case you get the Bloom syndrome, the Werner syndrome, and defective BRCA1 and 2 gene. Lastly, when the NHEJ is not working, in that case you get the SCID or the radiation sensitive SCID. Alright. Okay. Question number 14. Now, this is a DNA gel electrophoresis. Uh, just for reference, this diagram has been taken from my own thesis, so that there is no what you say that um, proprietary issues that I've there is some image taken from some book, so I've taken it from my own thesis. Okay, so a result of PCR is visualized using the agarose gel electrophoresis. And here we run controls. This is the control panel. You can see the different values are provided. The first one is 100, the last one is 1000. So it gives us a scale. We call it the scale or the ladder. Because of the pattern, it is called the ladder. It can be used to identify the unknown samples. See, the various samples are marked. This is 215. This is 480. So between fourth and fifth you have 480. Between second and third you have 215. So what will be between third and fourth? Somewhere between 300 and 400. The value should be somewhere between 300 and 400. Only value is 312. Only value is 312. So approximate value is seen based on the ladder. And please note, when we do the PCR, I always tell you that it is done for a known sequence of the DNA. So the result that you are going to expect is already known. What is the size of that sample you already know. So the size in this case is 312 base pair. It will lie somewhere between 300 and 400 sequences. Now, in the past, PCR was used only as the diagnostic tool, but nowadays we also use the product of PCR for downstream applications. In that case, we require the proofreading function in the PCR. When this question is asked, most of the students mark the Taq polymerase, but the answer is actually PFU polymerase. PFU polymerase. Okay. So PFU polymerase is coming from Pyrococcus furiosus. This PFU polymerase has two activities. It has the polymerase activity. Along with that, it has the helicase. It has the exonuclease activity. So it has the proofreading function. Because of that, it is able to perform very good we can say replication. There is very minimal error rate. So when you want to have the proofreading function. In that case, you require the PFU polymerase. Mitochondrial DNA is being asked again and again in our exam. About mitochondrial DNA, all are true except. So please note, it is a double-stranded circular DNA. Total 37 genes are present. Introns are not present. Only 13 proteins of electron transport chain will come from mitochondrial DNA. Okay, electron transport chain has 67 proteins. Out of 67, only 13 proteins will come from the mitochondrial DNA. So this point is not correct. Okay, please note this point is not correct. So answer in this case will be all proteins of ETC come from mitochondrial DNA genes? No, not true. This is the inheritance pattern for the mitochondrial DNA. So here what you have to note, an affected female will transmit to all offsprings, right? On the other hand, an affected male cannot transmit. An affected male cannot transmit the disease. Okay, an affected male cannot transmit the disease. So if you look here, what you'll find, female is affected, transmits to both the offsprings. Male cannot transmit the disease, female transmits to all the offsprings, female transmits to all the offsprings. So remember, in mitochondrial DNA disease, an affected female will transmit the disease to all the offsprings. An affected male cannot transmit the disease. So this is the inheritance pattern. Name of the some of the diseases which are due to mitochondrial DNA defect. So please note, most common is the MELAs, mitochondrial myopathy, encephalopathy, and lactic acidosis, stroke-like symptoms. It is the most commonly diagnosed mitochondrial DNA disorder. Most commonly diagnosed mitochondrial DNA disorder. The other disorders include the CPU, the Kearns-Sayre syndrome, Pearson syndrome, and infantile myopathy with lactic acidosis. Okay. Question number 18. Enzymes involved in formation of RISC complex include all of the following except options are drosha, pasha, dicer, and ribozyme. Please note, pasha is the other name for DGCR8, which is an enzyme involved in the RISC complex formation. So here the answer should be ribozyme. Drosha, pasha, dicer, all are involved in the synthesis. Quick look at the RISC complex synthesis. The polymerase 2 will synthesize the primary microRNA, which has the cap and the tail. It is acted upon by the drosha and DGCR8, which is also known as pasha. The cap and the tail are removed. This is the pre-microRNA. Pre-microRNA will then come out in the cytoplasm by the action of the exportin 5, where it is acted upon by the enzyme dicer. So now we have the microRNA duplex, which is then inserted into the RISC when we get the mature functional RISC. RISC stands for RNA induced silencing complex. RISC stands for RNA induced silencing complex. So as you can see, the drosha, DGCR8 or pasha, and dicer, these are involved in the formation of the RISC. Common donor to purine and pyrimidine include all of the following except. Your options are respiratory CO2, glutamine, glycine, and tetrahydrofolate. So here you have to keep in mind that glycine does not contribute to the pyrimidine synthesis. It does not contribute to the pyrimidine synthesis. Quick look at the purine synthesis. If you have this structure, the nitrogen 1 will come from aspartate, the carbon 2 will come from tetrahydrofolate, the nitrogen 3 comes from glutamine, 4, 5 and nitrogen 7 will come from glycine, the carbon 6 will come from respiratory CO2, carbon 8 again comes from tetrahydrofolate, and N9 comes again from the glutamine. It is again coming from the glutamine. Okay. In case of the pyrimidine, what is happening? This is N1, C2, N3, C4, C4, C5, C6. So here the C2 is the respiratory CO2, N3 is coming from glutamine, the rest of it will come from aspartate, and lastly formation of the thymine requires tetrahydrofolate. Okay, formation of thymine requires the tetrahydrofolate. So you can see the glycine is not required in pyrimidine synthesis. Glutamine, respiratory CO2, aspartate and the tetrahydrofolate are required. Saturnine gout is caused due to lead toxicity. The gout due to lead toxicity which affects the kidney is known as the Saturnine gout. The Saturnine gout is a type of renal gout. The important causes include the end stage renal disease or the CKD, the NSAIDs, the thiazide diuretics, any cause of lactic acidosis, and last is lead. These are the important renal causes for a gout. Important renal causes for gout, end-stage disease, NSAID, thiazide diuretics, lactic acidosis, and lead. Lactic acidosis can be because of any reason. It can be because of the severe exercise. It can be because of any alcohol intoxication, which is increasing the amount of lactate. Lactate competes with the uric acid for excretion. They have the common pump through which they are excreted. Okay. Now this is a trick question, very tricky. All the following enzyme deficiencies give rise to hyperuricemia, except you can see multiple options are there. Please note xanthine oxidase and PRPP synthetase. They will cause hyperuricemia when their activity is increased. On the other hand, the other three enzymes will cause hyperuricemia when their activity is decreased. So here the answer is xanthine oxidase or the PRPP synthetase. Glucose 6 phosphatase deficiency, you know, this is the von Guericke's disease. The HGPRTase deficiency is the Lesch-Nyhan syndrome, and allulase B deficiency is the hereditary fructose intolerance. So in these conditions we have the additional finding of hyperuricemia, and von Guericke's, the Lesch-Nyhan and the hereditary fructose intolerance, they will present with the additional finding of hyperuricemia. Very important image you can see here. What do you see here? The bite marks on the finger, bit of lips, the bite marks on the hands. This is the Lesch-Nyhan syndrome, which I just mentioned is due to the deficiency or absence of the enzyme HGPRTase. So here you'll have the self-mutilation tendency, here you will have the nephrolithiasis, here you will have the mental retardation, but there are no breath holding spells. Breath holding spells are not seen here. Okay, so in addition to this nephrolithiasis, you can have gout, you can have tophi, you can have mental retardation, you can have dystonia, you can have self-mutilation tendency, and you can have the very aggressive behavior. These are the characteristic findings in the Lesch-Nyhan syndrome: biochemical, neurological, and neopsychiatric. Okay. Question 23, microRNA cannot cause. MicroRNA we saw was part of the risk. Risk is present in the cytoplasm. So in the cytoplasm it can cause mRNA degradation, it can cause mRNA instability, it can inhibit the translation of messenger RNA. But the transcription occurs inside the nucleus. So here the risk cannot have any role. So this cannot have any role in the inhibition of transcription of messenger RNA because it is present as the risk which is there in the cytoplasm. Question number 24, in which RNA 5' end is capped? So here you have to remember the 5' end is capped in a product of polymerase 2. All product of polymerase 2 are capped. All products of polymerase 2 are capped, meaning messenger RNA capped, snRNA capped, primary microRNA capped, tRNA, the transfer RNA synthesized by the polymerase 3 will be uncapped. Okay, this is coming from polymerase 3, this will be uncapped. Okay, moving on to question number 25. Again, this is a very tricky question. Attachment at 3' end of tRNA after post-translational modification is poly A tail, 7-methylguanosine, 5-methylguanosine, CCA. Please note, 5-methylguanosine is not found anywhere. It is not attached to any of the molecules. 7-methylguanosine is attached at 5' end of not the tRNA but of the messenger RNA. Similarly, the poly A tail is present at the 3' end of the messenger RNA, but please note the question asking about the tRNA. So the CCA is present at a 3' end of the tRNA. Your answer should be CCA, not the poly A tail, which most of the students marked when this question was given. You don't have to mark the poly A tail. Answer should be CCA. Very good. Dr. Richpal Galva has marked it correct. The CCA is the correct answer. Single nucleotide polymorphism is due to, please note, the correct answer is a point mutation, also known as base substitution, is responsible for the single nucleotide polymorphism. Insertion deletion will commonly cause the frame shift mutation. It will commonly cause the frame shift mutation. Question number 27. Translocation of ribosome is carried out by. So here what you have to know, releasing factors, releasing factor 1, 2, 3, they are going to cause the termination. Elongation, initiation factor 1 and 3, they facilitate separation of 40S and 60S ribosomal subunits. Initiation factor 4E brings in messenger RNA inside the initiation complex. Elongation factor 2 will cause the translocation. So answer is elongation factor 2. Here you should also know about initiation factor 2. It will bring in the methionine tRNA in the initiation complex. It will bring in the methionine tRNA in the initiation complex. Okay. So these are some of the important regulatory molecules which are participating in the process of translation, that is protein formation, and their actions. CpG island is very important. What you should know about CpG island, these are activators in DNA. So CpG islands will show methylation. After methylation, there will be inactivation. Once the methylation is done, there will be inactivation. Okay, so remember CpG islands are activators. So if they are methylated, they will become inactive. Clinov fragment is of historical importance but still asked very commonly. Clinov fragment is obtained from the bacterial DNA polymerase 1. Now, in the bacterial DNA polymerase 1, if you remove the 5' to 3' exonuclease activity, then you get the Clinov fragment. So, DNA polymerase 1 minus the 5' to 3' exonuclease activity, the product is the Clinov fragment. Okay, DNA polymerase 1 minus the 5' to 3' exonuclease activity, that is the Clinov fragment. Question number 30. All are ribozyme except the 23S and the 28S ribosomal RNA are peptidyl transferase. All of them are ribozyme. The answer is 18S ribosomal RNA. 18S ribosomal RNA is not a ribozyme. Okay. Other ribozymes include the small nuclear RNA as well as introns. Both of them are involved in splicing. Also remember, the 23S ribosomal RNA is present in the prokaryotes. The 28S ribosomal RNA is present in the eukaryotes. Okay, both of them have the same function. They are acting as the peptidyl transferase. Okay, this we already discussed. The snowdrop, here answer should be the RNA. If you remember, we just mentioned the snowdrop. So you're talking about northern blotting, so answer should be RNA. Northern blotting, answer should be RNA. Now in this particular diagram, what is being shown? This is a type of modified Lagrange model, and what we are seeing here is alpha complementation. The alpha fragment is complementing the activity of the beta galactosidase. So this is known as alpha complementation. The LAC-Z fragment, this is called the alpha fragment. It is causing the complementary action, and therefore this is alpha complementation. This is a part of the blue white screen which is used in genetic engineering. This is a part of the blue white screen which is used in genetic engineering. Now Sanger used the DDNTP for sequencing instead of DNTP because what are the reasons? Which is the possible reason? DDNTP exhibit higher affinity for DNA polymerase? No. DDNTP exhibit lower affinity? No. Insertion of DDNTP results in prevention of elongation of chain by DNA polymerase. Okay, because DDNTP will not receive the next nucleotide. The deoxygenation is occurring at position 3 also. Normally the DNTP is deoxygenated at 2, but dideoxy is also deoxygenated at carbon 3, so the next nucleotide cannot come and get attached. A woman on antidepressant presents with bleeding. Bleeding means the vitamin K. She gives history of bulky stool which stick to pan. Which of the following vitamin deficiency can cause bleeding in this condition? Vitamin K is required for gamma carboxylation of the clotting factors. which clotting factors, which clotting factors 2, 7, 9 and 10. The factors 2, 7, 9 and 10, they are the factors for which the activation by vitamin K is required. And last question, which of the following is false about human genome project? This is question was asked very recently. So now here the options are somewhat ambiguous because it's based on recall, so we're not very sure about the various options. Among the given options, the best answer should be the next generation sequencing was used because this is a very newer development. This is not available at the time of human genome project. Although the time taken was about 2 decades, not more than that for the complete declared duration of human genome project. International collaboration was definitely used, and number of genes identified is 20,500. Okay, so among the given options, the best answer should be the next generation sequencing was used. So this is the discussion of all the different questions that you attempted during the bonanza of the biochemistry revision elite series. We have tried to incorporate a large number of questions from the previous few years papers, and I've tried to include the discussion from the on the topics wherever we need to know more information. I've gone to the details, particularly for the vitamins, a little bit about the carbohydrates, and a little bit about the lipid classification, a little bit about the structure of the purines, a little bit about the amino acid inborn of metabolism, the phenylketonuria, the tyrosinemia, the alkaptonuria. So these are some of the very frequently repeated questions. So if you have done the discussion seriously that you have covered here, you are likely to feel comfortable attempting the questions coming from biochemistry. However, this was just a representative sample of the type of questions coming in the exam. If you want more details, I would request you to visit our lectures which are in the available on the DocTutorials app. The whole lecture is available. We also have the quick revision program on the app, which summarizes the important topics in very short amount of time, the highlights which you must know for the exam. I hope this discussion session was useful and productive for all of you. Please keep preparing for exam and do attend all the other sessions which have been organized for you under the Elite Test Series program. They are going to give a big fillip to your preparation, and they will improve your output from your preparation. Keep preparing. Best of luck. Stay safe. Thank you. Bye.